Good afternoon, everyone. It gives me immense pleasure to welcome you all to this scientific session on obstructive sleep apnea, diagnosis to personalized management. This meeting brings together experts, researchers, and clinicians to share knowledge, discuss innovations, and explore how new developments can help us provide better care for our patients. It is now my honor to invite our head of the department, Dr. Jayalakshmi TK, to the stage. Dr. Jayalakshmi TK is not only an inspiring leader but also a highly respected clinician and teacher whose commitment to patient care and academic excellence has been a guiding force for all of us. We are privileged to have you here with us today to deliver the welcome address. And please.
So I really welcome all of you for this very important CME on sleep disorders. As we are seeing, with the pandemic of obesity increasing day by day, we are having many more patients of sleep apnea, and there are many aspects of it which don't normally get covered. So today's day, we are trying to cover those topics which will be useful after diagnosis for the management. Specific aspects of management which we haven't covered earlier. So without much ado, we'll just start with the lamp lighting and then we'll proceed with the program. Thank you so much.
For the lamp lighting, I would like to invite Dr. Jayalakshmi ma'am, Sanjay Karkare sir, Dr. Sudeep sir, Dr. Rahul Verma sir, Dr. Bhumika ma'am and Mahesh Bogre sir as well. So we'll right away start with our first session, when snoring is not benign, by Dr. Bhumika ma'am. So I'll use this opportunity to introduce the chairperson for this session. We have Dr. Sudeep sir. He's a consultant in critical care at Apollo Hospital. He holds an MD in medicine with a gold medal to his credit and further specialized with an FNB in critical care and the prestige EDIC qualification. He has also completed a diploma in ECMO from Paris. An avid academician, Sir is actively involved in teaching as a DNB and IDCCM faculty as well. We are honored to have him chair this session. Sir, please. Now I'll use this opportunity to introduce the next chairperson, Dr. Rahul Vinod Verma. He's a senior consultant in pediatrician and pediatric critical care at Apollo Hospitals, Navi, Mumbai. With over a decade of experience in pediatrics, he has special expertise in liver transplant, cardiac and bone marrow transplant intensive care, an accomplished academic with several publication and research contribution. We are honored to have him chair this session.
Thank you, everyone. We are honored to be invited as a faculty for today's scientific session of obstructive sleep apnea. We would like to thank Dr. Jayalakshmi ma'am, Dr. Bhumika, Department of Pulmonology at Apollo Hospitals, Navi, Mumbai. The first speaker for today's scientific session is Dr. Bhumika Madhav. She is a consultant pulmonologist and sleep medicine expert. She has more than 10 years of experience in managing complex pulmonary diseases. She has done advanced courses in sleep medicine, including pediatric sleep medicines, pulmonary interventions, and immunology and allergy. Dr. Bhumika, please.
Thank you so much, Jayalakshmi ma'am, for inviting me to present this session today. So my topic for today is when snoring is not benign, clinical cues to obstructive sleep apnea and diagnostic tools. So the most common types of sleep disorders are insomnia, sleep apnea, hypersomnia, narcolepsy, and parasomnia, out of which sleep apnea is extremely common. So in today's session, I will be talking about what obstructive sleep apnea is, the common symptoms, the risk factors, the history and physical examination for suspected OSA patients, validating screening tools, and various sleep studies. So what is sleep apnea? Sleep apnea is defined as a sleep-related breathing disorder which is characterized by repetitive episodes of complete cessation or partial reduction of airflow during sleep, which leads to oxygen level going down, desaturation, and arousals from sleep. So sleep apnea can be obstructive, it can be central, or it can be mixed. In central apnea, due to issues with the brain signaling to trigger respiration, this could be due to heart diseases, brainstem disorders, and obstructive sleep apnea is what we commonly see. It is due to relaxation or collapse of muscle which causes the muscle tones to reduce, especially during deep sleep and REM sleep. So more than 80% of patients with OSA are underdiagnosed. A little bit about epidemiology. The global literature in 2016 showed that OSA ranges between 9% to 38% globally. And there were many studies which show that in India, about 1 in 9 to 10 Indians may be having obstructive sleep apnea, out of which moderate to severe OSA may be seen in about 5 to 12% population. Closer. Okay. So OSA is underdiagnosed, especially in the rural and the semi-urban areas. What causes obstructive sleep apnea? So airway collapses, breathing stops, which disrupts the sleep and also results in snoring. So OSA is caused by recurrent obstruction of the upper airway during sleep. It can be partial or it can be complete. There is loss of muscle tone during sleep, and this results in intermittent episodes of reduced airflow and no airflow. So if you look at this picture, so this is the tongue, the soft palate, the clear airway. The tongue goes down, especially when we go to sleep. The muscles around the airway, they lose their tone. Tongue goes behind, and there is obstruction over here, which we can see, especially in obstructive sleep apnea patients.
Air travels down the throat, through the windpipe and into the lungs. The narrowest part of that.
So this video shows that when we sleep, especially in obstructive sleep apnea, the airway muscles relax and there is narrowing of the opening, snoring.
Obviously, many people experience this, but in some people, the throat closes so much that enough air doesn't get through.
So there is obstruction over here, the airflow is not going inside, which leads to brain signals causing the airway to open up.
And the brain goes back to sleep. This only takes a few seconds. You may not even know you've awakened. So
This process happens over and over throughout the night.
all night long, you may never get into the deep, restful stage of sleep. As a result, you may feel exhausted when you wake up, and if you really breathe, air travels down the throat.
So once in patients of obstructive sleep apnea, there is an airway which collapses, the breathing stops, sleep gets disrupted, and which results in snoring. There are various pathology and physiological mechanisms which lead to obstructive sleep apnea. So there are factors which promote upper airway patency, which is the pharyngeal dilator muscle activity, that is the genioglossus tensor veli muscles. Lung expands, provides longitudinal traction to the upper airways and reduces collapsibility. Factors which promote upper airway collapse: negative pressure within the airway during inspiration, extraluminal positive pressure due to skeletal, soft tissue, adipose or vascular structures, decreased lung volume due to obesity, which causes loss of longitudinal traction on the upper airways, which leads to increased collapsibility. So what is transmural pressure? Transmural pressure is basically the pressure which is inside the airway minus the pressure which is outside the airway. So if the transmural pressure is positive, the airway stays open, and if it's negative, the airway collapses. During sleep, especially during the REM sleep, the muscles which is maintaining the upper airway tone relax. Especially on inspiration, the patient generates a negative intrathoracic pressure to draw the air. When the intraluminal pressure becomes less than the surrounding extraluminal pressure, the transmural pressure becomes negative, which leads to airway collapse, which can lead to apnea or hypopnea. So in wakefulness, the transmural pressure is positive or neutral, and this keeps the airway patent. During sleep, the transmural pressure becomes negative and the airway narrows. And when there is obstructive breathing, the transmural pressure becomes more negative and the airway collapses further, prolonging the apnea. Looking at the physiological effect of sleep apnea. So during sleep, there is more of parasympathetic activity. But because of the recurrent obstructions and arousal, there is a increase in the sympathetic overactivity, which leads to the non-dipper pattern of nocturnal blood pressure. Intermittent hypoxemia can trigger the pro-inflammatory state. OSA also is associated with increased inflammatory markers such as CRP, IL-6, fibrinogen, etc. And OSA is associated with generation of reactive oxygen species. This also leads to increase in cortisol levels, leptin and other levels. So what are the symptoms of obstructive sleep apnea? So one of the most common symptoms that the patient come and tell you when they come to the OPD, the partner comes and tells you that my husband snores so loudly I am unable to sleep. So interrupted breathing during sleep, falling asleep during the day, restless sleep, loud snoring, irritability, forgetfulness, anxiety, depression, headaches in the morning, mood or behavior change. These are some of the symptoms of obstructive sleep apnea. So other than that, gasping during sleep, then low libido, poor memory and concentration, constantly feeling tired and unable to sleep properly are other symptoms. What are the risk factors associated with OSA? Obesity, male gender, advanced stage, post-menopausal status, then anatomical abnormalities, ethnicity, alcohol use and smoking. So it can be classified into anatomical, non-anatomical. Anatomically, micrognathia, retrognathia, facial elongation, mandibular hypoplasia, adenoid and tonsillar hypertrophy, inferior displacement of the hyoid bone, all may be having an increased risk of OSA. Then central fat distribution, obesity, advanced age, male gender, supine positions, pregnancy increases significantly. In pregnancy, the OSA can increase significantly. Alcohol use, smoking, use of sedatives and hypnotics, all of this may cause more reduction in the tone of the muscles. Then endocrine disorders and diabetes, metabolic syndrome, hypothyroidism, strokes, then other neurological disorders, Prader-Willi syndrome, Down syndrome, CCF, AF, all of these may be risk factors of OSA. So how do you diagnose obstructive sleep apnea? Detailed history with validated questionnaires and screening tools are extremely important. So I would like to urge all the doctors present here to please take a sleep history in history taking. It's very important. In our busy OPDs, we tend to forget taking sleep history. So the symptoms we have already discussed. Patients may have excessive daytime sleepiness, abrupt awakening during night, headaches in the morning, difficulty in concentration, memory, high blood pressure, sweating at night, decreased libido, and especially the bed partner comes and observes loud snoring, choking at night, and changes in the mood and gasping. So there are various questionnaires and screening tools which help in the diagnosis. Epworth Sleepiness Scale, Berlin, Modified Berlin Questionnaire, and Stop Bank Questionnaire are a few of them. This is the Epworth Sleepiness Scale. There are 8 questions in this. So we asked this to our patients in the OPD. The answers can be between 0 and 3. Questions like sitting, do you feel sleepy when you're sitting and reading, when you're watching TV, sitting inactive in public place, as a passenger in the car for an hour without a break, lying down to rest in the afternoon when the circumstances permit, sitting and talking to somebody, sitting quietly after lunch without alcohol, and in a car while stopped for a few minutes in traffic. So if the answer is 0 to 10, it's normal. 11 to 14, mild sleepiness. 15 to 17, moderate sleepiness. 18 to 24, severe sleepiness. This is the Stop Bank Questionnaire. So if the answer to this is between 5 to 8, there is a high risk of OSA. Between 3 to 4, intermediate risk of OSA, and less than 2 is low risk of OSA. This is the Modified Berlin Questionnaire that is divided into 3 categories. And based on that, we come to know whether there is a high risk or low risk of obstructive sleep apnea. Then physical examination. So increased neck circumference more than 17 in males, more than 16 inches in female. Patients may have hypertension, upper airway abnormalities. So in the nose, they may have deviated nasal septum, turbinate hypertrophy, nasal obstruction. Soft palate may be elongated or low-lying. Uvula may be enlarged or edematous. Tonsils may be hypertrophied. Tongue, there could be macroglossia, scalloping of tongue, hyoid inferior displacement. And the Mallampati score is very important. So Mallampati score of 3 or 4, there is more increased likelihood of OSA. Coming to what are sleep studies. So a sleep study, which is also called as polysomnography, is a comprehensive recording of biophysiological signals during sleep for the evaluation of sleep, sleep stages, sleep-related breathing disorders, movement disorders, and other sleep disorders. So these are 2 images where you can see there are electrodes which are put in the head, in the skull area to record the brain activity. Then there are electrodes which are put over here, EMG electrodes. Then there are flow sensors to measure the respiration. There is a chest belt and an abdominal belt. These are the various channels which are there. EEG is for the brain activity, EOG is for the eye movements, for differentiation between REM and non-REM. Chin EMG to check the muscle tone, especially for REM atonia and bruxism. Then there are leg EMG for PLMS, RLS. Then ECG for heart rhythm. Airflow, there are nasal and nasal thermistor, which basically helps us in differentiating between apnea and hypopnea. Thoracic effort and abdomen effort is with the help of belts. Pulse oximeter, snore mic, and a position sensor. There is also an ETCO2 monitor, which is recommended. So this is just a few of the ECG waveforms that we can see. So beta waves and alpha waves we can see when the patient is awake. Beta waves is basically when the patient is alert and concentrating. Alpha is when the patient is relaxed with eyes closed. Theta is in light sleep, which is usually seen in N1 and N2, and delta is seen in deep sleep. So this is just showing the, pediatric sleep, the electrodes connected to a child. Does everybody know Dr. Pal here? So this is just a video showing Dr. Pal also underwent a sleep study. So this video I have basically put to show you where the leads are connected and how the sleep study is done. So what are the various types of sleep studies? There's type 1, type 2, type 3 and type 4. Type 1 is the one that is done in the sleep lab. There are more than 7 channels which we record in that. The EEG, EOG, EMG, ECG, airflow effort and oximetry. This is done by the sleep technician who stays overnight, and it's an in-hospital study. So this is the gold standard. Next is a level 2 study in which again we have more than 7 channels, but there is no sleep technician and it can be done at home as well. And then type 3 is basically a limited study which is done at home. And in that more than 4 channels are used to record the ECG, the airflow effort, oximetry, all of these, at least 2 out of these, and this can be done at home. In type 4, mainly the oximetry is connected, but we prefer to do at least a level 2 or level 3 study at home. So there is level 1, which is the in-lab overnight polysomnography, and there is home sleep study, which may be level 2, level 3. So level 1 study is basically done for everybody whom we are thinking on the lines of obstructive sleep apnea. We are suspecting central sleep apnea. If you are suspecting PLM, parasomnia, seizure, narcolepsy, or complicated patients with underlying heart problems, CKD, for patients with persistent hypertension. So level 1 studies are recommended. Level 2, level 3 studies we can consider in those patients whom we are suspecting to have moderate to severe obstructive sleep apnea. So over here all those questionnaires come in hand. Patients with a higher stop bang, patient with a higher Epworth sleepiness score where we are having a clinical suspicion of OSA, we can consider doing a home sleep study. So this is my mother's case actually. She is a 71-year-old female, known case of diabetes, hypertension. She had a lot of snoring at night, interrupted sleep, fatigue in the morning, headaches, and a lot of sweating she used to complain about. So I got her level 2 sleep study done. I've taken her permission before putting the photo here. So the report was suggestive of moderate obstructive sleep apnea. If we have a look at it, the AHI over here is 21, especially in the REM sleep, and in the non-REM it's 17, and the total is 18. So she had a moderate obstructive sleep apnea. I started her on CPAP and her sleep efficiency is improved and her symptoms have also reduced after that. So types of sleep studies that we can do in the sleep lab, we can do a diagnostic polysomnography, titration polysomnography, a split night polysomnography, MSLT, which is multiple sleep latency testing, and maintenance of wakefulness test. How do you prepare for sleep study? In the next few slides, I'll be briefly talking about the preparation for sleep study. So you ask the patient to have a regular sleep-wake routine for the previous 2 to 3 days. Ask them not to nap on the day of the sleep study, to avoid caffeine and alcohol on the day of the test. Ask them to shower, wash their hair before coming for the study, and not to apply hair gel, oil, conditioner, makeup or any creams, because we have to put the electrodes on the scalp and the face, and if there is gel or oil, it becomes very difficult to attach it. So, with regards to medication, the patient is supposed to continue his regular prescribed medication, and they should let us know if the patient is taking sleep pills or psychiatric medications or some painkillers, because the tone of the muscles may be affected. So what are they expected to bring? They can bring their regular medications, they can bring their book to read if they want. Some patients find it difficult to sleep without their pillow or without their blanket. They can bring that along. And especially for pediatric age group, we tell them to bring their favorite toy, something that will help them cooperate. So once the patient comes to the sleep study, the technologist explains the procedure to them. Then they gently put the electrodes, which takes about 30 to 45 minutes. It's a very safe, painless procedure. So whenever the patient wants to go to the washroom, the kit can be disconnected and they can go to the washroom as well. In the morning, again the sensors and everything are removed and cleaned, and the patient has to follow up after a few days because we have to analyze a report which takes some time. So what are benefits of polysomnography? It gives comprehensive data. We are able to diagnose wide range of sleep disorders. It's in a controlled environment for accurate measurements, and immediate intervention of if any dangerous events can be done. The potential drawbacks are it's an unfamiliar sleep environment which may affect sleep quality. The cost is higher. This is the major factor for most of the patients, and they may have to take leaves for the sleep study. So coming to a few definitions, apnea and hypopnea. Apnea is cessation of airflow for at least 10 seconds. And in this, cessation occurs despite continued respiratory effort. Hypopnea. So hypopnea is scored when there is a reduction in the airflow which is more than 30% from the baseline, lasting for at least 10 seconds. Additionally, there should be at least a 3% drop in the oxygen level or an arousal, and an arousal may also be considered as a hypopnea. What is RERA? RERA is a sequence of breaths which is characterized by increased respiratory effort leading to an arousal from sleep. So when do we do split night study? In those patients where we are having high clinical suspicion of obstructive sleep apnea. If in the first half of the study the AHI is more than 40 for more than 2 hours, or between 20 to 40 in the repetitively lengthy obstructive event, and if there are major desaturations, then CPAP titration can be carried out, and if a CPAP titration can be carried out for more than 3 hours, then we can do a split night sleep study. So very briefly, I'll be talking about a few major indices that we look at. AHI. AHI is basically apnea and hypopnea per hour. This is what guides us in diagnosing the patient with a severity. Less than 5 is normal, 5 to 14.9 mild obstructive sleep apnea, 15 to 29.9 moderate OSA, and more than 30 is severe OSA. RDI is the respiratory disturbance index, which is apnea plus hypopnea plus the RERA. It also helps in diagnosis of upper airway resistance syndrome. So oxygen desaturation index, this is mainly looked at in the home sleep studies. Arousal index is the number of EEG arousals per hour of sleep. It is high in OSA due to sleep fragmentation. Sleep efficiency is the total sleep time divided by time in bed into 100. The normal sleep efficiency is between 85, at least above 85%. So lowest oxygen saturation is the lowest saturation which is recorded during sleep. Then time spent below 90% saturation is also recorded. Mean oxygen level is recorded. Snoring index is the number of percentage of beds with snoring, and CPAP pressure index is also recorded. So what will happen if we don't treat obstructive sleep apnea? So obstructive sleep apnea, there are arousals, and because of arousal there can be an increase in catecholamines which can increase BP, increase heart rate. It can cause hypercapnia, which affects the myocardial oxygen delivery. It causes oxidative stress inflammation. Then reduced intrathoracic pressure can lead to increased left ventricular wall tension, increase in cardiac oxygen demand. All of this can lead to hypertension, cardiovascular diseases, left ventricular hypertrophy, heart failure, arrhythmia, stroke. So there are various problems which can happen if we don't diagnose and treat obstructive sleep apnea. Depression, work-related accidents, especially there are a lot of people who are driving car and now are falling asleep. It can lead to serious accidents. Just a few myths associated with obstructive sleep apnea. Sleep apnea is just snoring. While snoring can be a part of sleep apnea, it's not the only issue. And just having snoring is not sleep apnea. It could be because of nasal congestion or some other issue as well. But loud snoring, which disturbs everybody else, we should consider of OSA. It's a man's disease. Although it's more common in man, sleep apnea affects both men and women. It's a weight issue. While being overweight increases the risk of sleep apnea, but anybody can be affected with OSA. Alcohol will help you with sleep. Although alcohol makes you sleepy, it worsens the sleep quality and apnea, and it is detrimental. So along with that, sleep hygiene is something which is very, very important, and I'm sure the next speakers are going to cover that in detail. Thank you. Quality sleep is not a luxury, it is a necessity.
Thank you, Dr. Bhumika, for setting the tone of the CME with a very nice and interesting talk on the obstructive sleep apnea. Any question from the audience? Pick.
Harris.
Pass the mic
Mike.
to the audience.
Hello.
Hello.
So, ma'am, thank you for the amazing talk you said. So, as primary care physicians, if we suspect, obstructive sleep apnea in some patient, so is there a criteria, or do we send all patients for a sleep study? Is there a criteria for a sleep study, or?
So the Epworth Sleepiness Scores, the stop bang, it helps in having a impression in my mind whether the patient could be having obstructive sleep apnea. If the patient has any comorbidities, then level 1 sleep study is gold standard. So in lab sleep study should be carried out for those patients. And for those patients in whom we are suspecting at least they'll have moderate to severe OSA, home sleep studies we can consider. So to answer your question, it's better to refer these patients, and then we can guide them accordingly.
So before sending the patient to you, would you recommend an ENT opinion to rule out, hypertrophic turbinates or deviated septum?
You can do that, but the symptoms of obstructive sleep apnea is not just snoring, it is more than that. They would be having daytime somnolence, morning headaches, they could be having snoring, choking sensation. So if all of those symptoms are there, then you have to do sleep study to rule out obstructive sleep apnea.
Right. Thank you.
If no question is there, we'll conclude the session. Thank you, Dr. Bhumika, for a nice
Thank you so
lecture.
much.
Now I would like to invite Dr. Nitin More to honor the chairperson as well as the speaker. Sir, please. Rahul sir, Sudeep sir. It was really a wonderful session, Bhumika ma'am. So we would like to move to the second session, Improving CPAP Compliance by Dr. Jayalakshmi ma'am. So I would like to use this opportunity to invite the chairpersons for the next session, Dr. Ravindra Nikalji. He's an accomplished consultant nephrologist and kidney transplant physician from Mumbai. Dr. Nikalji is a distinguished alumnus of GS Medical College and KMA Hospital, with MD in internal medicine and DM in nephrology, securing top ranking at Bombay Hospital Institute of Medical Science. I would like to invite him to chair this session. So the next chairperson for the session, I would like to introduce Dr. Mahesh Chavan, a highly respected senior endocrinologist from Apollo Hospital, Navi, Mumbai, with an MD from GMC Mirage, extensive experience across KM and MGM hospitals, and a strong academic background. He is widely known for his clinical excellence and dedicated teaching. Sir, please join me in welcoming Sir. So, the chairperson will introduce the speaker for the next session.
To invite Dr. Jayalakshmi ma'am. She does not need any introduction. Ma'am is an accomplished pulmonologist. She has been practicing here for a long time, and she has been leading pulmonologist in this area. And she was always in the forefront of this medical education. She holds multiple CMEs to this credit. So I invite Dr. Jayalakshmi.
Thank you, Dr. Bhumika. Thank you, Dr. Nikalji, Dr. Mahesh. Thanks to also Apollo Hospital and to ResMed for having sponsored this event. And today I will be speaking on, we are going one step ahead. Dr. Bhumika spoke about the diagnosis and about the tests which can be done and how we can diagnose. So after diagnosis, one of the treatments what we give her, one of the main gold standard treatments is prescribing a CPAP machine. But many times when we prescribe a CPAP machine, the patient is having lot of problems in using the machine. The patient has a perception that it is some kind of big cumbersome machine which I have to use every night. It's like an intrusion into their privacy, into the personal space of the patient, and it becomes a big big emotional and mental challenge for the doctor as well as for the patient to see to it that the patient is using the machine. So this we come to 2 points of compliance and adherence. So we will be going into that and how we can improve the utilization. Just like any medicine, unless the person is taking it, it is of no use. So let us see how, what are the challenges we face and how we can improve the utilization. So improving the patient compliance, practical solutions and patient education is what we will go into. So we will be speaking about the burden, the defining the PAP adherence, challenges with PAP adherence, impact of PAP adherence, ways to improve the PAP adherence, and we'll summarize. So if you see in 2019, the prevalence of sleep apnea was about 52 million, which has increased to 104 million. This is an Indian study paper which was done by Dr. Tejas Suri. So Dr. Suri is one of the persons who has done a lot of work in sleep apnea in India, one of the pioneers in our country. So he has said that around 104 million Indians of working age suffer from OSA, and of whom about 47 million have moderate to severe OSA. So this is a major public health problem, as later on Dr. Khare also will be talking about it. He's done a study which showed that so the incidence of sleep apnea is so high among the persons living around in our population. So why is sleep apnea so dangerous? Because it has associations with so many non-communicable diseases like hypertension, stroke, atrial fibrillation, heart failure, kidney disease, coronary artery disease, diabetes, obesity. How do you define the PAP adherence? So in the USA, when a person is prescribed a CPAP machine, the Medicare covers the cost. So they ask the patient and confirm whether the patient is using the machine or not. And by definition, they have to use it for at least 4 hours per night on 70% of the nights for a 30 consecutive day period during the trial. So if the patient is compliant, this is called as compliance, means they should use it at least 4 hours for 70% of the nights during the 30 day. Although actually this duration is also less. For the optimal effect, the patient should at least use it for 6 hours every night and almost every night. But this is the definition of compliance as per the definition which is for the Medicare coverage. So this is particularly for that. So what are the challenges we see? We see that 31% of the patients who started therapy with CPAP, they drop out, particularly in the first year. And 14% of the patients who started therapy dropped out in the first year in these 2 different studies. One was a 10-year study and one was a Latin American study. So what happens when the person discontinues and what happens when the person continues? So the therapy termination during the first year versus therapy continuation through the first year, there is a 39% increase in the survival rate for these patients. So this study has been done by a French group and they have studied the relation between CPAP termination and all-cause mortality. So they find that the all-cause mortality increases and there is a more than 39% chance of survival if the person is using the machine continuously. And there is a 25% reduced risk of developing hypertension, 23% reduced risk of developing heart failure. So CPAP significantly reduces all-cause and cardiovascular mortality. The cardiovascular mortality risk in PAP-treated patient, the reduced risk is up to 55%. And there is a dose response effect. So what we must realize is that even if the patient uses the machine for 1 to 3 hours in the night, many patients say that when we get up to go to washroom in the night, then we don't keep it back because it becomes a struggle to apply the mask again, or it becomes loose and there is a leakage, so we remove it because we are not able to adjust. So even if they use it for 2 to 3 hours in the initial part, still they get a benefit of using the CPAP machine. So you have to tell them that at least use it for as many hours as you can, and then we will slowly see about how to increase the usage. So these real world data shows a clear dose response relationship, and the benefits are seen even when we are using for 2 to 3 hours in the night. How do we increase the PAP adherence? So basically we have 3 types of problems. One is the machine related problem or the mask related problems. One is the patient related problem, that is they have Sometimes they feel their symptoms have not improved immediately, or they feel there is a machine, they are not comfortable, or they have a behavioral factor where they are not really disciplined enough to use the machine. There are other factors like socioeconomic factors. There are doctor-related factors where the doctor is not really able to explain the importance of using the machine to the patient. And there are machine-related, like if the mask is not okay, if it's poorly fitting, if there is an air leak and it is pushing into the eye and causing disturbance, or the patient is having a nasal dryness, or patient is getting claustrophobia. So all these things can be the reason for a poor compliance. So this study was done in India in Amrita Hospital, and it studied the acceptance and compliance of a continuous positive pressure therapy. In 75 patients it was done. So they have done the sleepiness scale, they have done the data on CPAP usage was collected, and they defined acceptance as the willingness to use the machine, and compliance using CPAP for at least 4 hours on 70% of the night by definition. And they did follow-up assessments at 1, 3 and 6 months. So this was a closely followed cohort. So in this study, they observed an acceptance rate of 62%. So in this population, the financial constraints, that is the cost of buying the machine, social stigma, and the preference for alternative therapies were the prime reasons for the refusal. And the compliance rates were good. They were 95% at 1 month, decreasing to 90% at 3 months, and 75% at 6 months. So you can see that even in this cohort, which has been closely followed up, there is still a 25% dropout at the end of 6 months. So what are the factors impacting the adherence in this group were mask discomfort, nasal dryness, inadvertent mask removal, and power outages. So these need to be corrected with patient education and support systems. So how to improve adherence to continuous positive airway pressure? So this was a paper by my teacher actually, Dr. Jyotsna Joshi. She has done this study or written from Nair Hospital, which is also one of the pioneering institutions where sleep medicine has been practiced right from the initial years, that is from 1997, the time when I was a resident. So that was a time when people had just started looking at sleep as a problem, and there was not so many studies which were available. So they have identified 3 problems. One is patient related, that is the ethnicity, disease and symptom severity, nasal resistance scoring, sinusitis, education about the therapy benefits, patient perception of benefits, comorbidities, social support, partner interaction, and psychological factors. Therapy related like aerophagia, pressure ulcerations because of the mask, skin changes, and claustrophobia. Many patients complain of claustrophobia. Like especially if they use an oronasal mask, they feel that, so patients who have a psychological problem with claustrophobia, they cannot tolerate a bigger mask. They will need to be given a nasal pillow mask where they don't feel so claustrophobic. Similarly with aerophagia, usually patients who require a higher pressure, they have this problem of aerophagia where they feel that there is a lot of gas or flatulence. So it happens in the initial part. Later on, as the patient gets adjusted to the pressure, that problem of aerophagia reduces. Pressure ulcerations, we have to usually change the type of mask or apply some type of sticker on the nose so that the mask is not directly hitting into the skin. And clinician related. So if the clinician has not explained to the patient properly the benefits of using the machine, or they have not spent enough time in explaining or demonstrating. So many times they say, okay, you give a demonstration, ask them to apply it in the daytime, in the clinic itself, apply the mask sit for some time. So many times when we do our sleep study, we also do the titration study. Many of our patients, when their first 3-4 hours comes positive, we do a titration study along with that. So we do a split night. So in this, the patient already has the initial experience of wearing the mask. They are in a comfortable setting, they are in a hospital setting, and they know that it is not risky, and they realize that it is safe to use the mask. So that becomes very beneficial in asking the patient to, when the patient wants to use it at home. So we need to also know about the patient's medical history, their social history, how the circumstances are, and also to get the confidence of the patient's bed partner or the patient's family, so that they also can reinforce the need for the machine. So we need to focus on education and counseling, intensive patient support, behavioral intervention, spousal collaboration, machine and interface related issues, conservative measures, and newer adherence monitors. So we'll go over some of the things. So one is patient characteristic like ethnicity. So depending on that, we have to advise the patient accordingly that this is a small machine. It really is not intruding into your space. You can use it, you can even carry it. Many patients have the fear that once we start using the machine, suppose we have to travel for a marriage or we have to travel for a business work. So can we carry the machine? Will we become addicted to the machine that we cannot sleep without the machine? So this becomes an important factor. So we must reassure them that it's not that they become addicted to the machine. They can sleep even without the machine like they are sleeping now. Only the quality of sleep will be much better when they are using the machine. And they can also carry it. It's very easy to carry the machine in the flight. It can be checked in as well. They can carry it with them with the prescription. So it's not really a problem to carry the machine at all. Many of our patients carry it when they go for conferences or weddings. So, in fact, we should emphasize that when they are traveling, it's all the more important if they are in a social setting or if they are sharing rooms with somebody, their loud snoring can disturb the others and become a big problem. So, that can be solved if they are using the machine. Similarly, increased nasal resistance. So, if they have sinusitis, so nasal resistance problems is one of the main reasons for reduced adherence. So it can be very simply solved by means of a nasal spray. Sometimes only a saline nasal spray is enough. Sometimes they need a nasal spray with an antihistaminic or a steroid which helps to loosen up the nasal passages and open up the passages. If the passages are small or if there is any block, then it becomes difficult for the patient to use the nasal CPAP. Sometimes they may require a surgical correction for a polyp or for a deviated nasal septum, after which their using of the CPAP becomes much better. Education about therapy benefits. So education is very important. So once they realize that few hours they have to use, it has so much benefit on their life, on their survival, heart reduction in heart disease. So this motivates them to use it. And patient perception of benefits also important. Sometimes the patient feels that we are not really benefited. The severe sleep apnea patients are usually having a much better adherence because they feel a remarkable difference. They see that we are now, even after doing one sleep study, when they come in the night and we do a titration for 4 hours, they say, today is the first day I am feeling awake. So these patients, they usually have a very good adherence. The problem of adherence comes in the patients with mild to moderate, whose perceived symptoms are not so much. Or if they have only snoring as symptom and they've been brought by their spouse for doing the study, so that gives them less motivation. So those patients usually drop out because they don't have any perceived problem, although the spouse may be happy that they are using the machine, but these patients are the ones who show a lesser adherence. And so we need the social support, we need their partner to keep motivating. And also to address the side effects, like we mentioned aerophagia, we mentioned about sometimes what happens if the mask is not properly kept, the air goes into the eyes. So this can cause dryness of the eyes, it can cause conjunctivitis. So this needs to be addressed. Pressure ulcerations and skin changes obviously need to be addressed, claustrophobia and other psychological factors. If they have insomnia, they find it more difficult to tolerate the machine. So sometimes we have to correct the insomnia also along with treating the sleep apnea. So these are the simple usual problems like leaks. So normally some amount of leak is there. That is an acceptable leak. Only if the leak is more than the certain percentage, then it becomes unacceptable and then you have to correct it. So better fitting mask. So in a mask also there will be small, medium, large. So there is something called as a mask fitting. So when you see the mask and you have to actually try it on. So many of the companies give a 3 size mask and ask them which is better and see the fit which gives a minimal leak. Whether nasal mask or oronasal, if there is lot of mouth breathing, sometimes oronasal mask is required. But most of the patients, even though they have small amount of mouth breathing, when they start using the CPAP machine, even with the nasal mask, usually that mouth breathing gets recovered and they start breathing normally. So that has to be tried. It's not that just because patient says, okay, I'm mouth breathing, or the relative says, then you have to immediately give a oronasal mask. Nasal mask is the main important mask for the sleep apnea because the correction, maximum correction anatomically occurs with the nasal mask. So oronasal mask only a small proportion of patients need, And many patients tolerate very well with the pillow mask, which is really a small type of a nasal mask. So rhinitis, it is important to treat, and if it did not exist previously, check for leakage, check for any allergies manifestations if it is there. Try with inhaled steroids, antihistaminics, ipratropium, and check again with the proper mask fit. You can use humidification if it is still not improved. So there is this humidifier which comes along with the CPAP machine. All patients in our setup don't really require humidification because being in at sea level with a sea nearby, we really don't need to add the additional humidification. But some patients may require that. Conjunctivitis we covered. Dry mouth, again, mask fitting and humidification. Noise usually comes because of air leakage. Otherwise, most of the machines are very, very silent. So they don't really make a lot of noise. Definitely less than the noise of snoring, if at all. Cold air humidification, removal during the night. So many patients say that we just remove the mask, we don't even come to know that we have removed it. So since we don't come to know we have removed it, morning when we get up, we find that the mask is not there. Actually, we have not woken up at all. So for such patients, they either have to take the help of their bed partner or they have to set an alarm, get up and check that the mask is there, put it on again maybe at 1 o'clock or 2 o'clock and then go on for the rest of the sleep. And anxiety, phobia. So for claustrophobia, smaller masks, smaller interfaces, and wear the CPAP when awake. So this, for patients who are not able to tolerate at night, the best thing, or those who get scared. So we had one patient who was so apprehensive to take the mask. He actually made our technician go and sleep with him for 2 nights, and it became a very big issue because he was not able, he was very scared to use the mask and he was staying alone. So for such patients, it's good that they use the mask during the day so that that fear complex which comes at night, that doesn't come. So in the day itself, when they are awake, they try on the mask and then for 1 hour, 2 hours, and then gradually start using it at night. And there is also some facilities in the machine itself where you can select the ramp facility so that the pressure will slowly increase. So the patient will not have a high pressure directly immediately. And also there is an expiratory pressure relief valve, so we can use that so that very high pressures don't really build up. And also it's very important to do a titration study so that we know actually what pressures are required. Many times what we do, the mistake what is done is patient is directly put on CPAP. And the CPAP has a range from 4 to 20. So because of that, there are fluctuations. And because of these high fluctuations, sometimes it actually wakes up the patient. So when we do a titration study and exactly put the pressure, what is required. So even in a CPAP machine, we have limits. There is a lower limit and upper limit. So suppose your sleep study showed that the titration pressure, mean pressure required is, say, 10. And the maximum pressure required is 12. So we can set the machine with the lower limit between up to 8 and upper limit at 12. So that even though the CPAP is fluctuating, it will give only that much fluctuation and it will remain more or less in that range. Because many of the auto CPAP machines are of quite better quality than the normal plain CPAP. Patients tend to go for the auto CPAP. But they can go for the auto CPAP, but they have to set their pressure range as per their titration requirement. And suppose they have not done a special titration study, they can see the compliance reports in the CPAP machine itself. And then that also will give us an idea of the mean pressure which is required. And then subsequently they can set the pressures accordingly. So early adherence predicts long-term use. So the first night, the first month, first week, these are very important. So it's good to call the patient within 3 days, within 1 week to follow up. And then see what problems the patient has faced, how long the patient has used the machine, see the compliance report. And it's seen that patients who skip the nights also use the CPAP for a lesser time. And even one skipped night can lead to return of daytime sleepiness and the neurobehavioral deficits. So we have to be clear. And it's not very clear as to how many hours exactly are required for optimum cardiovascular, neurobehavior and cognitive benefits. So there are still studies going on, but generally minimum 4 hours is required to see some specific good benefit. So greater nightly use gives greater symptoms. What are the symptoms which are improving? Daytime symptoms, sleepiness, neurobehavioral performance, blood pressure, quality of life. And this has been seen even with 1 hour per night also, this difference has been seen. So the interface mask we already talked about. There is a lot of evolution in mask technology now. There is better silastic glue or primitive straps are not now used anymore. We have different type of mask, hybrid mask, full face mask, nasal, pillow, oral. So there is no clear-cut studies which show that this type of mask is improving the adherence. However, subjectively, the patient experience definitely is better. So basically what have been studied, the age, gender, BMI, disease severity markers, marks, comfort, initial exposure and psychological barriers. So you can do with heated humidification. It depends on who has referred. Suppose the patient himself has got symptoms and come, the adherence is better. Suppose the patient has come because of a relative or a bed partner complaining of the snoring, then the adherence is little lower. If the patient has good knowledge of OSA and perception of treatment, it is better. Evaluation of patient awareness and assessment of symptoms is important. How does the patient generally handle challenges in life? That also becomes important because that same problem-solving ability they will put to this problem as well. We have to assess their claustrophobic tendencies, nasal resistance, whether it is there, and exposure to CPAP before some of the patients have already used CPAP in the hospital and they have found good relief, especially the patients with heart failure. These patients will show, if they have had a good experience initially, they will show a better response to the treatment. Severity has not shown much association with the CPAP adherence. Nocturnal hypoxemia also has not shown much adherence. Symptom severity is more important. So if the ESS is more than 10, then it has a good effect on adherence. And low adherence is seen in severe OSA patients but with less symptoms. So even though the AHI may be high, that doesn't predict that the patient will use the machine. If the patient has more symptoms, they will use the machine. Nasal resistance has shown to have a very good correlation with the adherence. So as I said, we have to if the nasal pressures are higher, there is a 50% greater chance of rejecting the CPAP. So nasal surgery has also been shown to improve the acceptance. So side effects do not consistently deter the adherence. The first experience matters. So if there's a technology attended titration, like how I mentioned in the sleep study, titration study, that can help. If they use for 1 hour technology, the technician is monitoring in the daytime, or at night if the technology is monitored, technician is monitored, then that gives a better adherence. So the education plus first night troubleshooting, that likely enhances the CPAP acceptance. So psychological barrier is claustrophobia. If there is a higher likelihood of claustrophobia, there is a higher likelihood to use for less. And this adherence improves. So the more hours the patient is using, even though the patient is claustrophobic, he slowly gets used to that and can overcome that feeling of claustrophobia. So in this case, the patient has to be encouraged to try and use the machine for longer period so that they can get used to it and not come back. So, first week is critical. Illness risk, the beliefs which the patient has on the benefit of treatment, on the willingness to use CPAP, this gives, and the patient's coping tendency itself, this gives a better adherence. Role of bed partner is there. Interventions to improve CPAP adherence, humidification, improve nasal symptoms, and heated humidification can be used, but these are more for the cold countries, not so much for our country. We have not found that much benefit with the humidification, but it can benefit for some patients. So the machine modality, fixed CPAP, bi-level CPAP, auto CPAP, flexible CPAP, and adaptive servo ventilation depends on the requirement of the patient. So I will just show you how. So this is one of the technologies which is available now. So with this, the patient can themselves see how much compliance they are having, as well as the doctor can see. So this is a technology by which the patient has an app. In that app, every day the reading comes, how much leakage was there, how much was the hours of use, how much was the AHI. So this all the doctor also can see with the remote monitoring, and the patient can also get the live feedback hour to hour and day to day. So this helps to improve the compliance. So this is the air view. So the healthcare providers can use this to see day-to-day data and have a real-time data as well as to how the patient is using and how much was the compliance and what was the pressures, what was the quality of PAP usage and what was the AHI during that time and how much was the leakage. So this is one of the compliance reports. So in this compliance report, we can easily get it from that app. So you can ask the patient to come back to you after 1 week after using the machine, and you will get the full data as to how many hours the patient has used, what was the AHI, and how many days the patient missed, if at all. So with this, we can be able to give a feedback to the patient, as well as we can correct the pressures if required, as well as we can do the troubleshooting for the patients. So this is the example of the compliance report where we can actually see how much the CPAP pressure has increased, how many days the patient has used the machine, how much was the minimum pressure, maximum pressure. And this is a patient engagement app as well. So when the patient is fitting the mask, there is a leakage which is immediately which can be calibrated from the mask itself, and it can be studied on the app. So which is the correct mask, whether the fit is okay, whether the leakage is okay. This, the patient gets a direct feedback from the app while using the mask. This is also these digital interventions are also very useful. And so the air view with My Air. So My Air for the doctor, air view for the patient. So it helps to improve the compliance. So in summary, the adherence to PAP therapy has benefits in terms of morbidity and mortality. It is challenging. Remote monitoring can help to improve PAP adherence. And we have an adherence of about 66 to 70% in our Indian studies as of now. And the combination of various technologies can help to improve the adherence as well as the other factors which we have covered. So thank you for the patient listening.
Excellent talk by Madam. So anyone in the audience has any questions can directly ask, Madam.
So maybe we can even cover the questions after all the talks.
Okay.
If no questions, we'll close the session. Thank you.
Thank you. So for angioplasty, definitely they can continue because they would have the OSA, that's why they are been given the machine earlier. Even for the patients who are having the bypass surgery, so as soon as they are weaned off their ventilator and they are all right enough, they should go earliest back on the machine because it will improve their oxygenation, it will improve their recovery time. So we should encourage them when they are in the hospital itself to go back to their CPAP therapy. Thank you so much.
I would invite Dr. Sanjay Khare sir to felicitate speaker and chairpersons. Mahesh. Dr. Jayalakshmi. Thank you, sir. Next session is of Dr. Rohan Aurangabadwala. For that session, I would like to invite Dr. Akshay Chalani sir as a chairperson. Dr. Akshay Chalani is a distinguished consultant physician and intensivist, currently serving as medical advisor and lead critical care at Apollo Hospitals, Navi, Mumbai. He holds multiple prestigious qualifications including DNB General Medicine, FNB Critical Care Medicine, FICCM, FCPS, and FICP. His leadership roles reflect his dedication to advancing critical care in India. He is the chairman of the Mumbai ISCCM, an executive committee member of the ISCCM West Zone, and also National Treasurer of ISSM. With his vast clinical experience, academic contributions, and dynamic leadership, Dr. Chalani continues to inspire the next generation of clinicians and intensivists. Please.
Thank you. Thank you. So I am privileged to introduce Dr. Rohan.
Our next chairperson is Dr. Rajesh Matta, sir. Rajesh Matta, sir, is an accomplished interventional cardiologist, advanced expertise in both coronary and structural heart interventions. He is postdoctoral fellowship in structural heart intervention in Turkey, following his DM in cardiology from KEM Hospital, Mumbai. Thank you. For next session, Dr. Rohan Aurangabadwala, sir. I would like chairperson to introduce Dr. Rohan, sir.
I had a privilege to introduce Dr. Rohan. Actually, is a chest physician and special interest in EBUS and tuberculosis. So today he will just talk about the patients who comes to you with COPD plus OSA, OSA plus pulmonary tuberculosis, or OSA plus other chest diseases. Sometimes we get confused. Patient with the COPD already on BiPAP, and now he develop OSA. So which mode we need to use, CPAP or BiPAP or any other mode? So next 20-30 minutes, Dr. Rohan will just throw light on this group of patients where there is a intersection between OSA plus other chest conditions.
Yeah, thank you, Dr. Akshay. So we'll be talking of intersection of OSA and respiratory disorders. Frankly speaking, OSA is intersecting with every other disorder that we can think of, be it cardiovascular, renal disorders. So it's basically existing, unfortunately underdiagnosed. But I'll be limiting my talk to respiratory disorders. So today's discussion basically will be a brief introduction to OSA, a term known as old OSA, that is obstructive lung disease and OSA, COPD and OSA, a little bit of asthma, OSA, ILD, PH, lung cancer, before we summarize the thing. So why are we talking about sleep apnea? It's a major and a very under-recognized public health problem. It's an independent risk factor we know for cardiovascular and a lot of metabolic disorders. Chronic respiratory conditions like COPD, asthma, interstitial lung disease often coexist with OSA, and they can exacerbate sleep-related breathing disturbances. So they mutually worsen each other a lot of times. So there is a synergistic relationship between OSA and these respiratory disorders, and it's often referred to as an overlap syndrome. A lot of time when we talk of overlap, it is mainly linked between OSA and COPD. It is less well studied with asthma, but more literature coming ahead with asthma, and also with interstitial lung disease. There is an increased morbidity and mortality when you take these disorders together as compared to an underlying disorder alone. So if you're talking of sleep apnea alone versus COPD alone, when you take both of them together, there is definitely an increased morbidity and mortality which is associated. And also there is a lot of inter-individual heterogeneity and prognosis of this disease. You know, not all patients of asthma may have severe asthma, or OSA may have severe OSA, but the interactions between the two may lead to more severity of symptoms. So for understanding that, we need to understand what is the respiratory physiology during sleep. So during sleep, a lot of changes happen in breathing. One, there is a change in lung mechanics. So there is worsening of the ventilation perfusion matching. So the VQ mismatch worsens during sleep. There is a decrease in the functional residual capacity, decrease in the end expiratory lung volume. There is a reduction in the respiratory drive. So your chemoreceptor sensitivity, so these receptors which control your breathing during sleep, is blunted. So your response to hypoxia, your response to hypercapnia is blunted. And this is going to be extremely important in patients who have underlying respiratory or chronic respiratory disorders. There is an increased upper airway resistance during sleep, which will contribute towards your OSA. There will be a hypotonia of the muscles during sleep. So as we know, during sleep, especially during REM, the tone of the muscles goes down, except for diaphragm, which is your main muscle of respiration. So these muscle hypotonia changes are much more pronounced during the deep sleep phase or the REM sleep. This all put together will lead to alveolar hypoventilation, worsening of hypoxia, and sometimes hypercapnia in patients who have an underlying respiratory disorder. The effects are usually mild and easily compensated in patients who are, or individuals who are normal. So an OSA patient, otherwise healthy, will not have so many changes. But an OSA patient with coexisting respiratory illnesses may have an exaggeration of these responses, which may, interfere with their overall quality of life, increase the risk of exacerbations, increase the risk of mortality. So this Aldosa syndrome, this was a term which was coined to look at the overlap of obstructive lung disease in general and sleep apnea. So if you see, there is a lot of overlap of symptoms between asthma, OSA, asthma, COPD. Sometimes there is even an overlap of asthma and COPD. And there are a lot of common risk factors, including smoking, obesity, GERD, which can worsen these individual disease entities. So the overlap is going to be even more worse. So if you look at the pathology or pathophysiology, obstructive lung disease will have a lot of systemic side effects, increased systemic inflammation. There'll be increased steroid use in patients with obstructive lung disease. All of this will increase your risk of sleep apnea. Now, sleep apnea also leads to a lot of systemic changes. That is, further increases inflammation. That is local as well as systemic. There is increased resistive load. There is increased bronchoconstriction. There is increased hypoxia. All of this will worsen the symptoms of the obstructive lung disease. So it's a vicious cycle which somewhere needs to be broken. A lot of research is there in COPD and OSA. This was the original term which was coined, was the overlap syndrome was for OSA and COPD. Now the prevalence of COPD in OSA in the general adult population is approximately around 10%. Now COPD patients have significant nocturnal oxygen desaturation during sleep because of, already as we said, ventilation perfusion mismatch and hypoventilation. They in general have frequent awakenings, reduced sleep efficiency and quality. In general, they have a reduced REM sleep. They have increase in the nocturnal hypoxic burden. All of this put together, even in the absence of sleep apnea, leads to increased risk of exacerbation of COPD, hospitalization, cardiovascular side effects of COPD, reduced survival, and a poor quality of life. Add to this OSA, it is going to be even more worse. So a lot of risk factors of COPD promote the development of OSA. The use of inhaled or oral steroids, the rostral fluid shift. A lot of patients have right heart dysfunction, fluid overload with COPD. In the lying down position, the fluid shift will be rostral, which will worsen the symptoms of OSA. Smoking is an independent risk factor, not only for sleep apnea, but also for COPD. All of this will promote the development of OSA. A few factors in COPD may be protective, especially the lung hyperinflation, the low body mass index, reduced duration of REM. We all know that REM sleep, the extent of sleep apnea is much more as compared to non-REM. And some literature suggests that treatment with theophylline has some protective effect on OSA, but not a very robust data. So there are factors which may promote or they may protect against the development of OSA. What actually translate depends upon what is the predominant thing, whether they are chronic smokers, whether they are obese, they are using too much of steroids. So that is where you have to be suspicious of OSA even in people who are lean thin. So what are the clinical characteristics or parameters which will lead to suspicion of OSA in this COPD patient? The symptoms a lot of times are going to be similar to patients even who do not have COPD. That is snoring, your witnessed apneas, unrefreshing sleep, daytime sleepiness, increasing frequency of micturition during the night. What should lead to suspicion? When would you want to check these patients for presence of OSA? If you have a COPD patient who is obese, who has a high BMI, a large neck circumference that is more than 42 centimeters or 41 in case of females, you have deranged blood gases. So you're treating a COPD patient, optimally treated, but has persistent daytime hypoxia or hypercapnia. You should be looking at a possibility of obstructive sleep apnea or obesity hypoventilation syndrome. Presence of pulmonary hypertension or right heart failure in otherwise preserved COPD patient should also lead to a suspicion of whether there is a coexisting sleep apnea. Presence of polycythemia and other comorbidities in patients with COPD, such as resistant hypertension, atrial fibrillation, heart failure, diabetes, stroke, end-stage renal disease. All these scenarios you should have a suspicion for OSA and check these patients of COPD for a coexisting sleep apnea or overlap syndrome. Now, what are the implications of this COPD OSA overlap? There is an increased risk of cardiovascular disease, higher prevalence of hypertension, peripheral vascular disease, diabetes, obesity, higher incidence of pulmonary hypertension, and right ventricular remodeling. It's very intuitive. COPD leads to hypoxia, hypoventilation, OSA, hypoxia. All this has a pathophysiological role in the development of pulmonary hypertension. Increased risk of arrhythmias like atrial fibrillation, higher risk of hospitalization because of exacerbations and mortality. Untreated obstructive sleep apnea and overlap syndrome is associated with increased risk of severe exacerbations, prolonged hospital stay, increased need for invasive mechanical ventilation, and higher mortality. So that is why we need to keep in mind that there may be an overlap, and treating both the conditions, that is COPD and OSA, or maybe other obstructive diseases and OSA, is extremely important in improving the outcome. So how does this interaction of COPD and OSA lead to increased cardiovascular disease? There is, the risk factors are common, that is obesity, smoking. All of that leads to hypoxia, leads to oxidative stress, increased systemic inflammation, sympathetic hyperactivity. All of this leads to endothelial dysfunction, increased risk of atherosclerotic plaque formation, and risk of cardiovascular disease. So that gets us to how do you diagnose? What would be the way to diagnose sleep apnea and these patients with COPD? The gold standard for patients with COPD where you are suspecting OSA is an in-lab PSG, that is a 11-1 sleep study with additional CO2 monitoring. So CO2 monitoring is important to look at hypercapnia, which is existing during sleep as well. And this is important especially in obese patients as well who may have CO2 retention. In laboratory titration, so once you have diagnosed, and if you need a titration study in these patients, in-lab titration is superior to the auto-PAP titrations. Home sleep studies, though they are more convenient, they are more cheaper. In patients with COPD, there is not a lot of validation of these studies, especially when there is concomitant respiratory failure. So if you have a type 1 or a type 2 respiratory failure in a patient with COPD, it is better to do a lab-based study as compared to a home-based sleep study. So OS should be suspected. So if you have a COPD patient who does not have other risk factors for sleep apnea, may not be obese, but when would you suspect? So if you're doing a titration study and you see excessive desaturation even with PAP or BiPAP, that is when you would start thinking that there is possibility of COPD in these OSA patients. Now, what is the treatment goal? The therapy goal is to improve the sleep quality, improve the indices from sleep study, improve the arterial blood gases, quality of life, and improve the overall morbidity and mortality. So reduce the risk of dying because of either of these illnesses. Optimal therapy of COPD is important. So you have to treat patients optimally as far as their COPD is concerned. You have to use rehabilitation in patients with moderate to severe COPD. PAP treatment is cornerstone treatment for sleep apnea. Only thing is which modality to use, which form of PAP therapy, whether CPAP, auto-PAP or BiPAP is not very clear. The choice will depend upon the phenotype. So if you have a patient who has predominantly OSA and not other signs of COPD, a simple CPAP or auto-PAP may be useful. But if there is severe emphysema with type 2 respiratory failure, you would want to use BiPAP as compared to CPAP, because it will help improve the minute ventilation in these patients and reduce the CO2 retention. Only thing is when you are using these devices, that is CPAP or BiPAP, in patients with COPD, you have to be careful about the PEEP levels which you are using. Modest level of PEEPs will counteract the auto PEEP which is there because of the air trapping in severe hyperthermia. But if you are giving excessive PEEP, it will worsen the hyperinflation and worsen the symptoms of COPD. So that is where you have to be very careful. You just can't give what pressures you desire in patients with COPD. So PAP therapy in patients with overlap syndrome in general, be it COPD OSA, be it asthma OSA, ILD OSA, will improve the admission-free survival, hospitalization rates, the arterial blood gases, the 6-minute walk distances, the lung function, exercise capacity, mean pulmonary artery pressure. It reduces the pro-inflammatory state which is existing in the body, which is implicated in the development of cardiovascular and cerebrovascular disorders. Same goes for asthma and COPD. There is a lot of coexistence of OSA and asthma. There is a high prevalence of both these disorders, and as more data comes in, we know that these disorders have a bidirectional relationship. Presence of one worsens the other and vice versa. And if you look at data, objectively confirmed OSA in asthma is almost up to 50% of the patients. And the prevalence increases with increasing asthma severity, and also higher asthma severity is associated with poor quality of sleep and increased daytime sleepiness. So what are the clinical presentations and the consequences as far as asthma patients are concerned? You know, if you have a higher BMI and worse daytime sleepiness in asthmatics, you should consider a possibility of coexisting OSA. Also, in patients who have frequent exacerbations or who are difficult to treat, you should always have a suspicion of OSA at the back of your mind. It is very well documented that untreated sleep apnea could be responsible for severe and difficult to treat asthma. So when you're looking at difficult to treat asthma, even before you reach the stage of using biologics and stuff, be sure you're not missing things like sleep apnea. And what are the consequences? We have already spoken that there is increased risk of exacerbations, poor quality of life, faster decline in lung function, improved, worsened morbidity and mortality. Therapy, as we said, the diagnosis and therapy for COPD is similar. You need in-lab studies, in-lab titration, and the cornerstone of treatment would be managing your asthma appropriately and managing the sleep apnea appropriately. Now, ILDs, we all know ILD is basically restrictive lung disorders, which will result in reduction in lung volumes and lung compliance. IPF, which is one of the commonest forms of ILD, has a very poor survival, and there is often a coexistence with sleep apnea. Regardless of the severity of the IPF, the presence of sleep apnea alone leads to significant decline in lung function over a period of time. Now, the prevalence in IPF patient in various studies ranges from 50 to 90%. It's extremely high. A lot of time we don't even think of all these things. They are on chronic steroids, a lot of ILD or connective tissue ILD patients. They keep putting on, weight, there is puffiness, they have sleep apnea. A lot of time we don't even start thinking of it. So we should always at the back of mind keep sleep apnea into consideration when we are treating these patients with chronic respiratory disorders. The typical symptoms may sometimes be missing in patients with ILD. Daytime somnolence only in 20% of the patients. Witnessed apneas 15 to 30% of the patients. Snoring around 40-50% of the patients. A lot of patients have fatigue, sleep onset and maintenance insomnia, and nocturnal cough. These are much more common as compared to the typical symptoms. Also, there is increased risk of pulmonary hypertension and cerebrovascular and cardiovascular diseases. And as a consequence, they have poorer prognosis and higher mortality. So if you look at the pathophysiology and the link, in IPF there is decreased lung volume, there is decreased traction of the upper airway, reduced upper airway stability and increased resistance. All of this increases upper airway collapsibility, increasing the risk of OSA. And the presence of OSA in these patients with interstitial lung disease will lead to recurrent stress injury, intermittent hypoxia, increased oxidative stress. Also, presence of GARD and microaspiration will worsen the interstitial lung disease. So both of these have a complex interplay and lead to worsening of both these disorders. Again, the diagnosis in even patients with type 1 respiratory failure or severe ILDs, you will need an overnight polysomnography, which will be a gold standard. It remains inevitable. CPAP will be a treatment of choice in moderate to severe patients with IPF. It is definitely associated with improved quality of life and sleep-related outcomes. Only challenges, as already in the previous talk, is that of claustrophobia and the cough. The problem in patients with ILD is severe irritating cough. So a lot of time that interferes with continued usage of CPAP. So you will have to address the cough appropriately so that there is improved adherence to CPAP therapy. As a rule, in laboratory titration is required for patients with OSA and comorbidities like ILD. Just a couple of slides on pulmonary hypertension and OSA. So pulmonary hypertension, though it's not purely a chronic respiratory, you have idiopathic pulmonary hypertension which may not be lead to respiratory disorders. There is a complex interplay with OSA which has to be kept in mind. OSA we know has a lot of cardiovascular impact, including systemic hypertension, heart failure, and the hypoxia which the OSA leads to, the inflammation which it leads to, will contribute to the pathogenesis of pulmonary hypertension also. So if you look at the prevalence of PH among OSA patients, it's almost up to 80% in certain studies. So you have to be very careful when you're dealing with patients with pulmonary hypertension, not to miss sleep apnea and not to avoid treating it. You have to treat sleep apnea in patients who have OSA and pulmonary hypertension. And the prevalence of OSA in patients with PH is almost up to 25%. So you need to carefully screen and diagnose sleep apnea even in patients with pulmonary hypertension. The treatment strategy is going to remain the same, that is CPAP therapy and oxygen if required. However, more research is needed for long-term outcomes and efficacy of this treatment. Interesting thing is lung cancer and OSA. A lot of times we don't pay attention to this even as respiratory physicians. It's quite often overlooked, maybe because of the severity of the lung cancer illnesses and stuff. If you look at this meta-analysis from the Annals of Thoracic Surgery in 2022, 30% higher risk of lung cancer in patients with OSA. So this is really high, something which is overlooked, and that is why it is important that we treat patients with OSA and look for OSA even in patients with lung cancer. The mechanism or the pathophysiology which is suggested is intermittent hypoxia and sleep fragmentation leads to chronic inflammation, oxidative stress, increased expression of the VEGF and hypoxia-related inflammatory factors. All of this will lead to lung cancer cell proliferation, invasion, microvascularization. So it could have a role in the development of lung cancer in addition to other risk factors for lung cancer, and that is why it is important to treat sleep apnea. So to summarize, OSA is an important, highly prevalent comorbidity for respiratory diseases such as COPD, asthma, and ILDs. Overlap syndrome refers to coexistence of chronic respiratory diseases and OSA in the same patient. Recent data underlines that they result in increased morbidity and mortality compared with either disease alone. OSA and respiratory disease may be of different severities. They have various clinical phenotypes, necessitating a individualized therapeutic response. You can't have one plan fitting all. Early recognition and OSA management could offer key benefits in terms of improved sleep quality, improved quality of life, improved disease outcomes, decreased morbidity, and decreased mortality. Thank you.
Any questions in the audience?
I think too much of sleep, as in
Dr.
lot of theory-based things. Practically not too much of cases or interesting stuff. But believe me, it's something which should not be undertreated.
Daytime sleepiness, that everything is okay, but those who are not obese, how to suspect this OSA in lean patient basically?
So there are a lot of risk factors. Obesity is only one of them. When you examine a patient, in addition to the symptoms, a lot of times retrognathia, you don't look at it. High arched palates, large tongue. So all these things are risk factors for sleep apnea beyond obesity. So those things have to be kept in mind. A lot of anthropometric things are responsible for sleep apnea, which we tend to overlook. We always think that a prototype patient is an obese patient who's going to have sleep apnea. Believe me, there are lean, thin individuals who have severe sleep apnea. They have other risk factors. They may have, large enlarged uvula. They may have tonsils. They may have adenoid hypertrophy in kids. Sleep apnea in kids is an underdiagnosed entity. They have chronic adenoid tonsillar hypertrophy. So they diagnose that and then they treat that. The kid's sleep apnea is taken care of. So a lot of other things have to be looked at beyond obesity.
last question to all experts. Suppose diagnose OSA, you use CPAP for 1 year, 2 years, and now the weight is reduced, everything is reduced. We can discontinue?
You repeat a sleep study. Ensure that it is negative, and then you stop. If it is residual sleep apnea, even after weight loss, you will have to treat. So weight loss is one of the modalities which will help. But if there are other factors which are not getting corrected, there may be a residual sleep apnea which may be there. Yeah, thank you so much.
Excellent lecture, Dr. Rohan, and we conclude the session.
Thank you, sir. Thank you for the session. I would like to invite Dr. K. Seema for the palliation of speaker and chairpersons. Dr. Akshay, sir. Dr. Rajesh, sir. Dr. Rohan, sir. For the next session, I would like to invite Dr. Sanjay Khare, sir. He will enlighten us on weight reduction and bariatric surgery in OSA. For this session, I would like to invite Dr. Bharat sir as a chairperson and Dr. Mahesh sir as a chairperson. Dr. Mahesh sir is a highly accomplished senior interventional cardiologist at Apollo Hospital. He holds MBBS, MD and DM in cardiology. And he is an international associate at the American College of Cardiology and also a fellow of European Society of Cardiology. Dr. Bharat sir is MBBS and MD in general medicine, and he is a renowned physician at Apollo Hospitals. He is holding around 15 years of experience in clinical at Apollo Hospitals. Thank you.
Hi. Good evening, everybody. So, we're going to talk about some therapeutic aspects now about weight reduction and bariatric surgery. So, we are talking about two conditions, friends, which are very, very, very common and yet sadly undiagnosed. Obesity, I'm sure in this very room, maybe something like 90% of us will be technologically classified as obese. And a lot of us are definitely going to be obstructive sleep apnea as well. So, unfortunately, very underdiagnosed. So my topic is whether weight reduction actually reduces obstructive sleep apnea symptoms, signs or not. Well, it's a half truth, so let's come to it. So, my entire talk, I don't want to make it a very didactic lecture or something. I want it to be straight from the heart, very, very practical. So whatever I'm going to speak, it's not going to be more of slides, it's going to be more of common sense, more of my own experience, some impracticalities or practicalities, some hard work which I've put in, and of course some mistakes which I've made, which are inevitable, I guess. A lot of it is thinking aloud, and of course the dictum is learning is and learning should be fun. So let's all learn. So my first topic is this guy. This poor old Indian guy groveling at the feet of a Western scientist. So why have I put up this slide? I'll talk about it in the slides to come. So we all know this, previous speakers have already talked about it. These are the symptoms of obstructive sleep apnea. We diagnose it or rule it out by stop bang. So a lot of practical things go in over here because of all these factors. We have obstructive sleep apnea. Mind you, obesity is only one of them. Obesity is only the tip of the iceberg. It is not the whole thing. So does everyone who has snoring has sleep apnea? Snoring isn't always sleep apnea. And of course, the whole thing is there is going to be a lot of vibrations. Why am I talking about this? In the ensuing slides, it will be seen. So how many of you have seen this film? Sunny Deol's first film, Betab, and then Arjun, I don't know. So the director of this film was this guy called Arjun Ravel, a very nice, young, dynamic director who peaked with these two films and then he's just stopped making films. The thing is that apparently he could not concentrate, he could not deliver, he could not take shots properly. People found him asleep during story sessions, and the climax came when he smashed his car in Varali. And he had to be taken to Bombay hospital. He was grossly overweight. He was diagnosed as obstructive sleep apnea. He was put on therapy. He recovered. So this is one first case which has been reported. All of you have known of Adnan Sani. This guy almost died. He was in Taj, and he was found, groveling on the ground, gasping for breath. So the bellhop came over there. He physically caught him, made him sit. The very next day, he caught a flight to UK. He got himself operated on. He denies it, but he's got an operation done, and this is his recent thing. The last guy wasn't so lucky at all. Bappi Lahiri was dead. He died of obstructive sleep apnea. So let us have some introspection as to what is OSA, what are the chemicals, what are the problems. And of course, this is my fourth slide. You know why? Lavaris is bastard. So unfortunately, sleep apnea is a bastard child, as is obesity. Now look at the similarities between these two things. Which faculty looks after obesity? Which factor looks after OSA? Is it a neurologist? Is it a pulmonologist? Is it a maxillofacial surgeon? Is it an ENT person? Is it a bariatric surgeon? Or is it somebody who believes in metabolic medicine and who's got a bird's eye view of everything which is going on? So if I say that the next decade is going to be the decade of a metabolic physician, I don't think I'm too far off, right, Bharat? Physicians would like to believe that. But at this point of time, this is the scenario. This is the three blind mice, and nobody the heck knows what's going on over there. So everybody is looking after something, every department is chopping after something. But the thing is that we need something for the simple reason that obesity, obstructive sleep apnea, and cross morbidities and mortalities are in parallel with each other. Look at the sad fact, obesity is grossly overlooked and underdiagnosed, as is obstructive sleep apnea. Something like 80% of people are just not diagnosed. And even of the 20%, most of the idiots don't use the CPAP. Believe it. I have banged my head on the wall, trying to make a diagnosis, make them wear the CPAP machine. It's all futile. In the UK, people are given CPAP by the state, and yet they say that 26% non-compliance. Okay? In India, the problem is worse. We have 40% compliance. So 60% are non-compliant. So either they refuse to have the diagnosis or to wear the machine or to be adherent to it or be convinced about the pathophysiology. God alone knows. There is tremendous resistance either to go for the test or to go for the therapy. So in fact, I have made actual DVDs in my clinic. I tell them, look, this is what your problem is. But somehow, it's very difficult getting across. I don't know what your experience is, Jaya, Bhumika, but it's a very difficult thing to convince to the patients. They agree, but the whole Indian psyche is, and look at the parallels again, it's a very bemusing parallel. I'm not obese, अच्छे खाचे घर का है वो, खाता पीता हूँ. The guy is grossly obese and the mother proudly says, नहीं, थोड़ा सा healthy है. अरे साला healthy काहे का है? आगे चल के घंटा लगने वाला है उसका. The thing is, थोड़ा सा healthy है. In the same way, थोड़ा सा snoring होता है. And now in Indian things, थोड़ा सा snoring is considered normal. So I say it's just not the snoring, go beyond the snoring. So all of you must have observed in the last 20-25 years, baldness is gone up, myopia has gone up, obesity has gone up, and I don't care a heck what happens to us. This is our future. This is pathetic. If we have any pediatrician over here, he or she will tell us that this is the gross, it is a shame that India is right now the second most populous pediatric population. But in the next 6 months, we are going to overtake China also. So obesity and OSA are like this, they are the two sides of the same coin. So why is it that all of us are getting bald? Why is it that all of us are getting obese? And why is it that all of us have OSA 100%? So is it epigenetics, which is like change in genes? Or is it because of excessive intake or reduced output? Is it pollution? Have you read the Times of India a couple of months ago? Pollution itself is supposed to be a contributory factor for obesity and most of the ischemic heart diseases. Only pollution. Or is it because of crops that we eat from pesticide-laden fruits on plants? Is it because the dairy which we are drinking or curds which we are having are from oxygenized animals? Is it because of electronic pollution? All sorts of electronic gadgets over here, are they playing havoc with the system? Or is it because of some microwave eaten food? All these, or mobile radiations, infections. Some some viruses are supposed to cause obesity. All or none, you take your prawn. The thing is, obstructive sleep apnea and obesity form a combination which goes beyond hypoxia. There is systemic inflammation, and because of these particular factors, they all correlate that the person is doomed. Obesity, OSA, the person is doomed. So the thing is, at a very rock down level, there is increased sympathetic activity. Because of a lot of factors which will come into it, because of there's vasoconstriction, there is platelet aggregation, and because people only feel that, okay, I'm a little healthy, I just snore a little, but this is what happens. Statistically, a lot of them are going to end up with a stroke or a heart attack or a congestive cardiac failure or all sorts of disorders which we'll talk about. Same over here, because of the dip in intrathoracic pressures, it takes a heavy toll on the heart. And because of this, there is a systemic inflammation. So like I keep telling all my patients, obesity is not so simple. It is not only about not being able to fit into a bikini or not being able to fit into a jeans. No, it's far more than that. There is systemic inflammation in obesity, because of which there is going to be every organ involvement. And as everybody knows, we are not an island of organs. All our organs talk to each other. There is a cross-talk between organs. So whenever you have obesity, whenever you have obstructive sleep apnea, because of the hypoxia, because of the sympathetic drive, there is not a single organ which goes untouched. Why? Because of all these chemicals. Cytokines, amyloid, CRPs, tumor necrosis factor, interleukins, VCAMs, selectins, neutrophil lymphocytic ratio, platelet. And the other thing, the most important thing is, you lose obesity, you lose obstructive sleep apnea by judicious use of CPAP. Lot of these cytokines are actually demonstrated to come down. Now, just one latest thing, it has been reported by the Arizona University that there is one new chemical, I think you guys, the residents should know about this. There is a new molecule called choline, C-O-L-I-N, which has just been isolated maybe a week ago. So choline has found to be underrepresented in people with obstructive sleep apnea and obesity together, because of which it also causes NASH, non-alcoholic steatohepatitis, fatty liver. And every time the choline levels go further, the damage because of obstructive sleep apnea, obesity and NASH increases, and these cause increase in Alzheimer's disease. So in fact, this study was published in the Journal of Alzheimer's Disease in Arizona University. And after losing weight, after correction of obesity and obstructive sleep apnea, choline levels actually rise. So there's something very interesting. So OSA is not only at the level of CPAP, it goes way beyond that. And as I've said, a lot of improvement, these cytokines actually fall. And that's why I call obesity and OSA a syndrome. It's not a simple disease. So right from ADHD to Alzheimer's, and something now I've really started believing what I've seen. Have you seen the kids nowadays? They just can't seem to concentrate. You ask them, what's your name? Where do you stay? I mean, as kids, I'm sure if we could have a dialogue with our seniors, or at least give one meaningful sentence, their entire vocabulary, it's like Gills the Two-Leg syndrome, Their attention focus is pathetic. They can't sit for a long time. They cannot maintain eye contact. I don't know whether they actually have a lot of attention deficit disorder syndromes or not. And now this choline study actually proves my doubt, So Alzheimer's, depression, strokes, diabetes, you know it and you know it. So friends, what are we dealing with? Does OSA cause obesity or does obesity cause OSA? This is a murga and anda situation, because a lot of thin people also have OSA, mind you, and they then become obese if they are undertreated. Why? Because of these chemicals which are released from uncorrected OSA and uncorrected obesity. So cortisol goes for a toss, which causes systemic inflammation, we all know it. Leptin, it's one of the most important hormones known, because of which your satiety and your hunger comes into play, which goes for a toss. And ghrelin, like you stop eating for a day or something, your ghrelin levels go sky high. And because of this, you eat more and you become more obese. And obesity is such a horrible disease, it's almost like cancer. So basically what is cancer? Unregulated cell replication, because of which the organs don't work anymore. What is obesity? Same. You have restricted obese cells which multiply, they infiltrate into every damn organ known to mankind and they bugger up that particular organ. So is it not as bad as cancer? It is. So skinny people also have apnea. So my common things is there a correlation between baldness, myopia, obstructive sleep apnea and obesity? Well, yes. In myopia, what happens? The muscles basically go for a toss. They become a little lax, so that focus is lost. So when I got my specs in second MBBS, there was this book called Better Sight Without Glasses. Like an idiot, I picked up that book from British Council, and they had mentioned a lot of exercises. So I stopped using my specs and I kept doing those exercises till I was miserable, because it doesn't work. Because the muscles becoming lax is only one aspect of it. So in the same way, the muscles which become lax over here are only one aspect of it. So in the same way, all these three have something, and the pathophysiology goes way beyond structural problems. There's something which is at a chemical, at a cytokine, at a hormonal level. So basically, now we have some things which have been given by international reports. The interaction between obesity and OSA, does it actually cause, does weight loss reduce or get rid of OSA? Well, it's very difficult to say. For example, being a bariatric physician, let me tell you one thing. It's bloody difficult to get rid of even a single kilo of weight, and even more, maintaining that damn weight loss is even more of a challenge. So okay, let me give you an example. If you want to lose 1 kilo, you have to lose 6,600 kilocalories. All right? So every time you run for something like 30 minutes, Rajesh, you are going to waste 350 kilocalories. And then ghar mein aane ke baad you have one vada pav and you put on 425 kilocalories. Life is cruel, isn't it? So that's the maths. So that's why getting rid of a single kilo is so difficult, and maintaining that weight loss is even more difficult. So theoretically, we doctors will say, "Hane thoda sa vajan kam kar." Arey vajan kam karo, kaisa kam karo? It's so difficult. And maintaining that weight loss is even more difficult. So that's why, yes, weight loss will definitely accrue in reduction of your pressures in CPAP, but that's not the whole truth. The CPAP damn machine is not going to go away, just like my specs never went away. Understand that? It will reduce, the machine will reduce, and that's why what we need is a multidisciplinary and integrated approach, and that's what we have been doing over here. So that's why we have formed this department called ICOM, that is Apollo Institute of Clinical Obesity and Metabolism. So I'm the lead physician. We have a dietitian, a nutritionist, we have a yoga expert who I'll introduce you later. We have a rehabilitation expert, we have a counselor, because we need a counselor to go inside the mind and tell the patient to hog less without being miserable because of the rises in ghrelin. It takes tremendous all-round approach. So even the Indian studies which actually show that yes, you can reduce the OSA intensity, the pressures, but that damn machine is unlikely to go off. Now let's come to this slide about our poor Indian scientists. Kitna saal we are going to get enamored by the gori chamdi and go extremely by the Western standards. We are different. Rajesh can vouch for the fact, and Mahesh can vouch for the fact that our coronary anatomy is different compared to a Westerner. Our metabolic profile is different. We are toffee, which is thin outside but fat inside. So we Indian Asians are probably more notorious. In spite of being less obese compared to a Caucasian, we fare less better on the scale of longevity and on the scale of betterment. We don't do well. We are probably more inflammatory. Our platelets are probably more aggregatory, or whatever you call it. So we are different. And that's why the entire definition has been changed. So in fact, we have metabolic physicians, they've been writing to the ICMR, and finally ICMR took a heed, and about 2 years earlier, they revised the definition of obesity in India. Previously, the BMI was supposed to be okay if it's about 24, 25, not anymore. Now the ICMR says that an Indian person, BMI is better off at 22.5. Anything which is more than 22.5 is high. So the whole point is, we are different and we have to do our own research. Fine, we'll agree by the Western standards, but that's not the whole thing. So that's why myself, in my clinic, Apollo and NMMC, Navi Mumbai Mahanagar Corporation, we did a survey of 3,300 people in Navi Mumbai. All the these things were statistically, we were correct, we made an analysis. And what we found out actually was that the OSA was extremely rampant in this particular category. OSA is one of the most underdiagnosed conditions. A lot of us are obese. In our study, we found that 58% of people who have been studied were obese, of which almost nobody exercised, a whopping majority did not sleep adequately. A lot of them was Zomatos and Swiggy eaters. In this shell, everything which should not be done, we have been doing. So this was our study and we have published it. We've also published this particular study which we did. And this is something which I want to talk about. This is a first-hand experience about does weight loss reduce OSA or not. So we did this study and we actually also involved Tanuja, who was with us at that point of time. I asked our patients to undergo these exercises, palatal, pharyngeal, buccal, labial, tongue exercises and all sorts of things, along with weight loss. So this is our study which showed that a whopping majority of people dropped a lot of weight. At least 5 to 6% of their body weight they lost. But the OSA did not go away. The pressures came down, but the machine stayed. So this is what the problem is. So now Apollo, Central Apollo, Raju Vaishya, who is the head of academics, he had asked me to write a book on obesity, which is probably the first book in India, if not in the world. So I have contributed a couple of chapters and I have also edited Pan India, all the Apollo series. So I and Vidya have written a book on chapter on obesity and sleep disorders, something which is very different. Just like choline, which I talked about, this particular chemical, mTOR, which is the mammalian target of rapamycin, which is a new chemical which is just being introduced into the world literature. Again, an inflammatory marker and which goes in direct proportion to obesity and to obstructive sleep apnea. The worse the obesity, and this is the higher the levels of mTOR, and that translates into a cardiovascular and oncomalignancy disaster of the first order. Good news, you reduce weight, mTOR comes down, and now those guys are so smart, they are starting making monoclonal antibodies against mTOR. Everolimus has been tried, and it actually reduces mTOR, and which translates into the OSA being reduced. So something which is very interesting. So at this point of time, as of circa December 2025, weight loss, yes, 100%. Whatever you call it, bariatric surgeries or whatever lifestyle changes, pharmacology. Now we have 2 or 3 great molecules, you know. So we have Mounjaro, which is tirzepatide. We have semaglutide, which actually work. And of course, bariatric surgery is the cornerstone. So the weight goes away, but it actually stays over here. So now some new advances, hypoglossal nerve stimulation, diaphragmatic stimulation, a lot of gadgets, a lot of things. So this is my favorite story. Once Kishore Kumar was riding high and everybody was flocking to him, and poor Muhammad Rafi was just sitting in a corner, you know. So Kishore Kumar, at the height of his career, he had the grandiousness to tell people, Gana yahan pe hai, but Sangeet wahan pe hai. Go take his signature. So in the same way, there is something called wisdom and there is something called knowledge. So whatever we have talked about so far has been knowledge. You know, this study, this trial, that meta-analysis, all that is okay. But where is the wisdom? Where is the wisdom? There is something which is terribly wrong, right? All of us. How come all of us are suddenly started getting bald and suddenly getting myopic and suddenly getting obese in the last 50 years? Kahin pe to there is some problem, right? There is something which is going wrong somewhere. Never has human beings so obese as in the last 50 years. Why? So the answer over here is something which our forefathers have given to us maybe 2,500 to 300 years ago. And that is how to make our life on planet Earth so very beautiful. Integrate with something from other and roots to planet Earth. So, do you guys know what I'm driving at? Yeah, it's yoga. So something which is priceless as far as I am concerned, and something, you know, rather than popping a pill or injecting yourself, I really do believe that the truth comes over here. So in fact, I have terrific faith. I'm a hardcore allopathic doctor. I'm a Bombay University gold medalist, but I have terrific faith in yoga. So that's why I have gone out of my way to invite Kishore Patil. Rajiv, can you please set up? So Rajiv is an accomplished yoga teacher, and I have actually requested him to join our bariatric program, and he is there for our guidance in Apollo. So he has been conducting some sessions for my obese people, and I'm rather happy with the way he's going about it. Thanks. So how does yoga work? Well, it works at a multiple level. So there is something called knowledge, there's something called wisdom. I feel yoga in my personal capacity yoga gives you some sort of an inner intelligence which tells your brain exactly how much to eat, when to say no. Basically, what is yoga? Yo is Surya and Ga is Chanda. So, combination of solar and lunar energies. It has been proven that used properly, it actually balances the sympathetic and the parasympathetic nervous system, which is what we want. Because hasn't modern knowledge told us that there is a tremendous increased sympathetic activity and reduction in intrathoracic pressure? That's what yoga does. So basically what yoga does is does all these sort of things. And what does pranayam do in OSA? In the same way. So it balances the swings in intrathoracic pressure. So these are some forms of pranayam. Rajiv is an expert, so if any of you is interested, please do flock to him. So post weight loss, the pressures of CAP finally definitely go down. Clinically, the volume of snoring will go down. Now, weight loss by whichever method, by non-clinical, I mean non-pharmacological, pharmacological, bariatric, whatever. So what does literature say? How much weight you have to reduce? Very funny, and I think I have to talk about this. It's so simple. Reduction of even 2% of your body weight. I'm not talking kilos, I'm talking 2%. 2% of your body weight will reduce the systolic blood pressure by 5 to 10 millimeter mercury. You reduce 5% of your body weight, your diabetic tablets will go down by 50%. You reduce 10% of your body weight, diabetes will be in remission. You lose 15% of your body weight, a lot of illnesses just go away. Very easy to say and bloody difficult to practice. You're not talking about 2 kilos, you're talking about 2%. But if you do that, that's what happens. So, the patients feel better, there's no doubt about it. Daytime somnolence also reduces. But an official overnight sleep should and must be done, because in my humble opinion, a lot of people stay back with residual OSAs. So if you are using an auto CPAP, the machine will take care of it. If you are not, I think it's better to document. In fact, one of my first bariatric surgery patients over here, Vigyan Jain, had operated. He was 136, and after that he came down to something like 94. He was very happy with himself. I have just sugar gaya, ye gaya, wo kya, I'm not even taking a glycomet. I said, great. And what about these things? I stopped using it. I said, why? I don't need it. He says, who? He's saying, no, my wife doesn't complain, I am better. I said, can you humor me and just get a sleep study done? So Jaya had a technical problem. It costs 25,000 rupees and above. Insurance is not available for a standard test. 22,000. So insurance is not available. A lot of times the appointments are not available. So I really do feel that we have to maybe malleate a little, maybe organize a home sleep study, level 3A, 3B, whatever. The thing is, this Charlie stopped using his CPAP machine and he got into a false sense of security. Sure enough, he came back 18 months later with a weight gain. Now he was 112 or something and back to square one. So sad, but this is the truth. So this was my last slide. So the take-home message, we are dealing with something which is a nuisance. Obesity is tough for the patients and it's frustrating for the doctor because the damn weight doesn't go down. Even if it goes down, it's known to recur. But the good news is now we are being flooded with pharma industries, great products. In the next 2 or 3 years, we are going to get terrific medications. We are going to get orforglipron, which is an oral tablet. We are going to have triple agents. We are going to have once a month shot. We are going to have twice a week jabs. We are also going to have a medicine which not only reduces the weight, it also stimulates skeletal muscle growth. So future is rosy. So like I was just talking, I think the next decade belongs to metabolic medicine. There's no doubt about it. But till that time, it's an ominous racket. Obesity, weight loss, you get rid of the one thing, the other thing persists. It's a vicious circle. So the thing is, weight loss will help tremendously, but it is not the end all and be all. Some amount of disability is going to stay. Thank you so much.
Really eye-opener talk. Many new things we have listened today. Thank you. Any questions from the audience, sir?
Oh, superb. So now we have two injectables. One is semaglutide and one is tirzepatide. Tirzepatide is a dual GLP and GP1 agonist, and semaglutide is a single GLP1 agonist. So anybody who does not have pancreatitis and who does not have CA thyroid can use it safely. So it can be used. The things being that if the BMI is more than 30 or 28 with comorbidities, you are officially allowed to use it. You are officially licensed to use it in India even if there is a non-diabetic obese person, no doubt, no problem about it. So they are expensive, something like 10 to 12,000 rupees per vial, per injection rather, and एक महीने का खर्चा will be about 10 to 12,000 to start with for 2.5 milligrams, and then after 1 month you are supposed to graduate to 5 milligrams, which will work out to about 13 to 14,000 a month. It is lifelong. It is a one-way street. Don't even think about stopping it. You stop it, you are going to regain all your weight back. But then that's true for most medicines, right? We can't even stop thyroid medicines. You can't stop blood pressure medicines. You don't stop lipid medications. That's the way it is. Side effects are zero. So the thing, I was waiting for somebody to ask it. So this Canadian study was released maybe 72 hours ago. So there was this study which said that a lot of people have suicidal tendencies. Now, Girish, as a neurophysician, you know there are these carotenoid systems, CART, so which is cannabinoid and receptor agonist system. So that's the reward system of your brain. So why do you eat? Because you feel good. Why do you have sex? Because you feel good. Why do you have heroin? Because you feel good. So the satiety centers stimulate. So these agents, they block the satiety centers, the GLP agonists and all that, and because of which you don't have that urge to eat, because that happiness is given to you pharmacologically. That translates into some sort of a depression, and it has some sort of a suicidal tendencies. These agents have not yet been given the red flag, but there was one particular medication which was released with a huge fanfare and which was withdrawn at 72 hours notice, anti-obesity medication. So that was rimonabant. So rimonabant came with a bang and people started banging their heads and they had suicidal tendencies. That was withdrawn. But then a lot of you pulmonologists use secondary medications for resistant tuberculosis. 2 of those also have suicidal tendencies, right? So every medicine has an effect. As far as this is concerned, it is yet not officially recognized. In my experience, and I use a hell of a lot of patients, Girish, I have not seen a single patient going into depression. Suicide is far away. There was another scare about ICON, which is acute optic atrophy. Bullshit. Never happens. Not a single patient has been declared in world literature. Now, these factors may be because of politics. It can be because of a rival person feeding wrong information also. But at this point of time, there's no documented. But that is what is done. It would be idiotic to start only one particular medication. So in fact, I'll not come to that, but yes, I mean, I personally never start these medications without lifestyle modification. In fact, Kishore, we all work together, we just don't do that. That's not possible. So even in Lilly literature, they say that 70% people benefit. I quietly ask them, what about the remaining 30%? But then what about bariatric surgery? Bariatric surgery, I'll show you a dime a dozen people who have regained weight. So lifestyle modification, that's why I've said over there. Multi-system, multi-team approach is a given. You just can't shoot without that. No way.
I mean, is there any correlation between this?
Which have shown that especially in the Mediterranean areas, so siesta concept came from Turkey and Maldives and that belt, Greece, Macedonia, even in India, the whole thing is it's a geopolitical situation. It's blazing hot outside. It makes sense to take a 30-minute siesta, but never more than 30 minutes. Because then if you sleep for more than 30 minutes, the melatonin levels in the evening go down. You don't get good sleep in the evening. There have been huge amounts of studies which show that a good siesta actually increases your productivity. So siesta in the afternoon without snoring is not a manifestation of OSA, it is a cultural thing. Cyprus, that was the country I was thinking about. Cyprus, it started in Cyprus, the whole culture. And then it caught on in Italy and all that. Are we done? Pune, yeah. Pune is extended, 1 to 4. Vaishali, it's 1 to 4.
Thank you, sir. We'll conclude.
Thank you, sir, for an absolutely wonderful session. So I would like to invite Dr. Dayanand P. Babar to felicitate the chairperson as well as the speaker.
Seeing you over here, I can't resist the temptation. Girish, GLP analogs have been found to have tremendous benefit in Alzheimer's and dementias and in Parkinson's. Yeah. Yes. It is also found to be of tremendous benefit in psoriasis. Yeah. So it's going to be the wonder molecule of tomorrow. I think migraine ke liye olmesartan has been given this thing. Today's JAMA.
Dr. Sanjay Kare, sir. Mahesh Gogre, sir. Bharat Saraswat. So we'll quickly move on to the next session, Management Strategies in OSA by Dr. Pavan sir. So I would like to introduce the chairperson for the next session, Dr. Vaishali ma'am. Dr. Vaishali ma'am is a senior consulting physician at Apollo Hospital. She is an MD and a DNB examiner, a respected faculty member, and an active speaker at MMC accredited CMEs and national conferences, with special interests in diabetes and geriatrics and several publications to her credit. We are honored to have her chair this session. So I'll introduce this next chairperson, Dr. Ashwati Haridas. She is a consultant nephrologist and transplant physician. She completed her MD in medicine and DM in nephrology from the prestigious KM Hospital, Mumbai. She has led important research in acute kidney injury and transplant hepatitis C management and has several national presentations and publications. Please welcome Dr. Ashwati as the chairperson for this session. Now the chairperson will introduce the speaker for the session.
Thank you, Dr. Harris, and thank you, the team, for inviting us. I'd like to invite the next speaker, Dr. Pavan Kumar Biraris, a very well-known face here in Apollo Hospital. He is a senior consultant, also associate professor, faculty for pulmonary oncology at TMH Mumbai. He's also working at the Center for Lung Health, Nerul, as a consultant. He has done his DNB in pulmonary medicine with DTCD and advanced training in interventional pulmonology from Bangalore. Also a European diploma in adult respiratory medicine at Switzerland. He also has a fellow interventional pulmonology degree at thoracic endoscopy from Italy. He has several publications to his credit. He's performed more than 5,000 basic and advanced interventional procedures in pulmonology. Also has, to his credit, pioneering work in oncopulmonology. He's got the gold medal for his national DNB examinations during his post-graduation. Multiple research papers. He's the co-founder and faculty for fellowship in pulmonary oncology at TMH Mumbai. And of course, a great speaker. Pavan, we would love to hear from you. Over to you. Thank you.
Thank you so much for that lovely introduction. The topic given to me is management strategies in OSA, and from CPAP to personalized therapy. And you have seen how Madam has spoke about how to diagnose, how to treat with positive pressure ventilation. Dr. Rohan has very nicely highlighted the interaction with respiratory system. And our beloved speaker has spoken very nicely about the role of obesity, weight reduction, and all those. So my job is to compile all these things together. If you can reduce the echo for the nice. Yeah. Okay. So, okay, sir. So, each patient has to be approached holistically, and the aim of this my talk is that you should be able to diagnose, treat them, or at least refer the patient appropriately, diagnose, get it treated by a sleep specialist, and monitor them carefully. Majority of you are the first person of contact for most of these patients and dealing with their family. OSA is a family problem. It's not an individual problem. So let's look at this life model of individual patients across the age and the disease burden. And if you don't treat OSA diagnosed at age of 30 or 40, if you don't treat it, lot of comorbidities set in. It reduces patient's quality of life, family's quality of life, lot of financial burden, multiple comorbidities, and eventually it has its effect on cardiovascular and CNS system, leading to patient's mortality. But with therapy, if you diagnose it early, there is a window, effective time period where patients are receptive, doctors are receptive, the family doctors, their families are so receptive and they work together that you can benefit in that window, diagnose early, give them effective therapy so that over a period of time they become as good as the individual without a sleep apnea. A traditional model, we suspect depending on the patient's symptom, we diagnose them with polysonography, we offer them a CPAP, which is the common trend in management, and you somehow follow, patients lost to follow, somehow those who follow, you manage them carefully and they benefit. But as it has been discussed earlier, 68% of patients lost to follow up. They do not use it after 3 to 4 years. So what should be done? A tailored therapy. Individual patients' individual patients' phenotype is totally different. So you don't have to only address the symptom or a AHI or apnea hypoapnea index. Look at the risk factors. Look at the financial background. Look at whether they can afford it. Look at how the CPAP therapy can be managed. What are the different endotypes? Each patient is different. All 5 fingers are different. Similarly, each OSA obese patient is different. We may not have the genotype of Western population, but the pathophysiology remains the same. The OSA pathophysiology is same, and you have to target individual thing. A thin person still can have a OSA because of the neuromuscular dysfunction, because of the upper airway pharyngeal muscle dysfunction causing airway collapse and leading to obstructive or sometimes central sleep apnea. So how you will treat? You will look at the treatment options, and we are going to discuss these treatment options in this talk. But look at patient preference. I'm ready to offer them a surgery, but whether patient wants a surgery, whether patient can afford a surgery. If I'm ready to offer an CPAP, whether he's ready to take CPAP long term. So patients, it is a shared decision making. It's not my doctor has prescribed CPAP, please use it, and that's it. That my job doesn't end. In fact, Once the sleep apnea patient is diagnosed, you are married to the patient. He's going to trouble you even at night times, telling you that there is a leak in my machine, and what should I do? And that's where the ResMed-like people come in picture, where they can help these patients at home with appropriate follow-up. You have to look at what are the predictors, what patient will respond to what therapy, what machine, what interface. Every visit is going to contribute to patient's quality of life. And there are a lot of modalities which are coming up, lot of modalities, adjuvant therapies you can offer, which we are going to discuss. So it's a shared decision making between a healthcare provider and a patient. When to decide about treatment of patient? You look at patient's symptom. You don't only look at the AHI number. Patient has got severe sleep apnea, let's start treatment. Patient is symptomatic or not? What are the comorbidities? Even a mild sleep apnea, hypertension or coronary artery disease patient may qualify for a treatment. Look at patient's preference, what he deserves, whether he's willing for a weight loss, whether he wants to try weight loss, other positional therapy, whether he's ready to use some positive pressure therapy rather than a CPAP. Look at those parameters as well. And it's patient's bed partner, patient's family is equally involved in patient's treatment. They are equally troubled by the sleep apnea as well as the sleep treatment. So we have to take feedback from the family as well, who is going to encourage them to stick to the treatment. This is our diagnostic and management algorithm. If patient is symptomatic, treat it. Treat with severity of AHI, what kind of OSAs, central apneas, complex apneas. Look at whether there is oxygen desaturation or not, and then formulate a therapy plan for that patient. If the patient is not symptomatic, he denies all the symptoms. The family says he's a strong snorer. We have seen him choking. Rely on that and start the treatment. Even a asymptomatic patient, but you have a moderate to severe sleep apnea on AHI, please consider treatment for that as well. Those who are mild, not symptomatic, you can offer them the adjuvant therapies and follow them carefully clinically. So four pathophysiological concepts which have been, therapies have been defined on basis of that are the effect of airway mechanics, effect on muscles, effect on respiratory drive and arousals. And our neurologist will tell you how the alpha to beta, theta to alpha transition happens, beautifully seen on the EEG. Even if the patient appears to be sleeping, his brain is awake. His brain is shifting his sleep stages, feeling like the patient is awake and causing daytime excessive sleepiness. So we are going to concentrate on some therapy which will help you to open the airway, some therapy which will help you to modify the engineering of the respiratory drive. If there is some disturbance in the respiratory drive, lot of ventilatory compensation can happen, can cause CO2 going down, O2 going down, respiratory depression, prolonging apneas. So lot of phenotypes are based on this. That's why not all patients benefit from only PAP therapy. They have to have some adjuvant therapy along with that. So we are going to talk about reducing the anatomic load, neuromuscular modulation, neuroventilatory modulation, and some correction of residual daytime sleepiness. If you look at the patient's anatomy, this is a windpipe, there is a static obstruction and there is dynamic obstruction. Static means what? You have a tonsil, you have an adenoid, you have lot of pharyngeal, peripharyngeal fat deposition. These are all static obstructions, fixed obstructions. You have large tongue, only modifiable with help of surgery. So those are static obstructions. Dynamic means each phase of respiration, the obstruction is changing. These are mostly the muscles and the neuromuscular pathways. So how we can modify it? You give a positive airway pressure to dilate the airway, to give a pneumatic splint to keep the airway open. You can use myofunctional therapy, and we are going to discuss about it. Strengthen the muscles, pharyngeal muscles, so that the dynamic collapse reduces. And then you can use surgeries or oral appliances to relieve the fixed or static obstruction. Among the neuromodulation and reducing the sleep depth, you can use multiple medications, though not clinically shown 100% effective, but they are supplementary treatment for the OSA management. So this is, majority of you will encounter this patient. This is a patient referred to as 64-year male, multiple comorbidity, diabetic, hypertension, IHD, typical metabolic syndrome, has ejection fraction of 47%. He has atrial fibrillation. He is James Bond of India, having been obese. Complaints of snoring, EDS, means excessive daytime sleepiness. He is watching TV, reading a book or talking to a wife, and he's dozing off. So that is the excessive daytime sleepiness, and there is a ESS score. You can calculate whether the patient is really sleepy or it is just wife complaining that he doesn't listen. There are choking episodes. Patient can choke at night times. There are witness apneas. They snore. They suddenly stop snoring, and a very loud snore, which will wake up a kid, that will happen. That is a choking episode. But this patient who was denial of his disease, no, I don't have any disease, who was offered a home sleep apnea testing, and it showed that there is a severe OSA. Now each sleep, I think Bhumika has covered it. Each test gives you whether obstructive or central sleep apnea can be detected. EEG is necessary to diagnose a complex sleep disorder, but at home, yes, you can diagnose an OSA. This patient denied his disease, denied the treatment, but he was offered CPAP. Somehow the family convinced him to just start CPAP. So practitioner gave him a 12 centimeters water pressure CPAP, a continuous positive airway pressure with a nasal mask. You can see that nasal mask given to patient. So when you look at a sleep apnea patient, it is not only AHI number. There are a lot of intricacies involved. OSA patients can be insomnic. They don't sleep at night times properly, or they are very sleepy. So there are different phenotypes which needs to be addressed with multiple therapies designed for this patient. Age, the child and the elderly's EEG or neurophysiology is different. Their sleeping patterns differ. The elderlies have a lot of muscle weakness. So there are dynamic airway collapsibility is more. Child may have a tonsil and may develop an obstructive sleep apnea. So there are different phenotypes of OSA. Then the comorbidities, the CPAP adherence, and a lot of endotypes. I spoke about the 4 pathophysiological parameters, and depending on that, the endotypes are defined, and depending on that, therapy has been designed for that. So the primary line of treatment is PAP. When should we give PAP? AHI more than 15, moderate sleep apnea or a mild sleep apnea with symptoms, or patient has neurocognitive impairment, loss of concentration, excessive daytime sleepiness, hypertension, multiple cardiac comorbidities, or a history of stroke. They qualify for a sleep apnea treatment with a positive airway pressure. So how you screen this patient? When this patient came to us, he was diagnosed with sleep apnea on basis of a home sleep study and given a CPAP. But what can be done better? You can prefer an in-lab titration, especially if the patient is a high risk. If he has multiple comorbidities, morbidly obese, prefer in-lab titration for these patients, and then decide about the CPAP treatment. The other modality is give auto CPAP, which has been a fixed CPAP was given to this patient, but you can give auto CPAP, then gauge over a period of 2 to 3 weeks what pressures they require. A P90 or a 95 value can be given by that machine, and you can gauge that what pressure is required for that patient, and then you can prescribe the same fixed CPAP pressure rather than giving empiric pressures to the patient. The other one is the direct auto CPAP, and this is the common practice nowadays. You just give auto CPAP at home and patient will be taken care of his sleep apnea. So on follow-up, patient may tolerate it or he may not, and he may have multiple issues, and that's why a close follow-up and troubleshooting of this. Otherwise, within 3 weeks, your patient will say, I don't want to use this machine. It's troubling my sleep. I used to sleep something, now I am not able to sleep. So that's why adherence to the treatment is better predicted and better made by proper counseling of this patient. So this patient had what issues? He was not tolerating the CPAP. He refuses to use it as he was not acknowledging the disease itself. And the issues were lot of pressure, lot of leak I have seen, and his symptoms are same. No point in spending this. Nowadays these machines are available on the rent. 6,000 rupees per month. He says, no, it's useless. I didn't sleep. My symptoms didn't get better. So what can be done? Carefully follow this patient. Educate him about his disease, his family. Try to get the confidence of the patient knows some benefit is going to be offered to me. Appropriate interface. He was given nasal CPAP, a fixed nasal mask machine, and probably that was interfering in his treatment because he was mouth breather. So he used to have his mouth open and he used to have a leak through his mouth. So the pressure was not sufficient. You should have a follow-up plan from your patient. So each patient should be followed in 2 to 3 weeks time with a PAP download. All these modern machines have a smart card data. They will give you the hours of use, compliance, leak, and AHE, that is apnea, hypoapnea, event information. Depending on that, you can decide this patient is getting benefited from the sleep machine or not. So if it is adequate, compliance is good, getting benefited, continue same machine. If inadequate, please follow that thing. Now this patient who had a home sleep apnea testing could have been offered, in hospital another sleep study, but patient will say, why I want to spend 25,000-30,000 rupees again, which for the therapy which I am not going to take in future. But if you can improve his compliance, but somehow his life will change. So you have to convince this patient on basis of personalized treatment, and you can offer some adjuvant therapy. People like to be talked about non-medical part, weight loss, diet, and all those things as well. So a personalized approach can be given in positive pressure. What can be done? You can give an auto CPAP to this patient, which will adjust as per patient position, patient's weight, his REM sleep, non-REM sleep, he is in deeper sleep, he's in a rapid eye movement sleep, depending on that, the pressure requirement will change. So auto CPAP may become a good choice for this. It can be a replacement for in-laboratory titration. Patient may not, they may not want to spend another night in hospital with a titration test. So it can help you to gauge a fixed CPAP. And ultimately, it widens your mean airway pressure with minimum pressure provided. So patient feels that this pressure is good for me and he tries to use it further. So it improves the tolerability and compatibility. It doesn't mean that all patients should receive auto CPAP. No, it will help you to come to a conclusion that what minimum pressure is necessary to improve this patient's condition. So even a home sleep study was done, you can use auto CPAP if the symptoms are milder, if there are no comorbidities. A flexible PAP, a continuous pressure with the help of 12 pressure, if the patient tries to breathe out, he will not be able to breathe out. He'll feel suffocated. So in that situation, you can use a flex PAP. It means at the expiration, the pressure drops to a certain level. If you are given a 12 pressure, at the end of expiration, at the start of expiration, the pressure drops to 8. So the patient feels easier to expire and he feels better with the machine to use it longer. But remember that auto CPAPs and these maneuvers should not be used if the patient is hypoventilating, like a morbidly obese OSA or a congestive heart failure patient who can have a central sleep apnea. In that situation, better not to try it, better to do a titration study for them. So what titration study will help you? It will help you to gauge the pressures so that you can shift this patient if required to a BiPAP if the pressure requirement is high. 15 and more pressure requirement, prefer to have additional titration study. If the patient still has symptoms, he has OHS, he has COPD, he has central sleep apneas, better you use a BiPAP for that. And a simple titration maneuver, if your sleep technician is good, he will give you overnight, but the sleep technician has to be good to give you a reliable result on the titration study as well. So if you have prescribed sleep app, what mask you will prefer? What is the ideal mask to give? So there is no ideal mask, but a nasal mask should be used. What we feel is oronasal mask will cover the airway and better and it will pump the pressure properly. But if you look at the pathophysiology, if you give nasal pressure, a nasopharynx open up, oropharynx widens and the pressure delivered is proper. If you give only oral pressure, your tongue is pushed back, your soft palate is lifted and your actual airway chokes on that. So it's preferred to use a nasal mask with a chin strap. If the patient is mouth breather, a simple Amazon available chin strap can be used. But if the patient is frequent mouth breather or the other comorbidities, then you can use a oronasal mask. Functional MRI pictures showing how nasal CPAP can be useful versus a oral CPAP which is choking the nasopharynx actually. So the interface, selection of interface is also personalized. This patient nasal mask, mouth breather, has leak, is non-compliant. But when you gave him the chin strap, he started using the machine. If not, what can be given? Oronasal mask still can be tried, or there are other masks like nasal pillow. A pillow which will deliver a pressure, tolerate the pressure up to 12 to 14, can be easily given in the nose, and patient's compliance, patient tolerance is most of the times better. Or you can use, if the patient feels claustrophobic, if there is a lot of pressure over the nasal bridge, in that situation you can use a hybrid mask which will use nasal pillow plus oral mask. So that the patient tolerance, the compliance, you have to try everything possible for first month so that the patient sticks to the treatment. Appropriately, a nasal mask with a chin strap is better, and there are measures, there are calipers available to measure what size fits to the patient, and the technician can provide you easily. For patients who have COPD, ventilatory defects, OHS, ILDs, already having type 2 respiratory failure, you prefer a oronasal mask because the tidal volume delivered is better. That time we are actually dealing with a ventilatory thing. And explain the intentional leak. Each machine has it has pores, so the expiration becomes easier. So you have to explain that you will have some amount of leak which is intentional. Beyond that, if there is a leak seen at the eyes, if eyes are getting red, machine is not fitting properly with a change of position, that are excessive leaks, and that has to be addressed. Otherwise, the patient will not benefit from your positive pressure. What are adjuvant therapies? Weight loss, I think Dr. Khare has spoken very nicely about it, so I'll not speak too much. But you have to consult a dietitian. You have to advise for the exercise. You have to take a help of endocrinologist or a metabolic physician who will help to decide about whether a GLP-1 agonist will help this patient or not. And the surgery is one of the options when all the options fail, and if patient is affordable, morbidly obese, like Adnan Sani, who can try gastric banding or endoscopic as well as the major surgical option. Positional sleep apnea. Sometimes the sleep apnea is more in the supine position than a lateral position. Because the tongue falls back, your pathway chokes. So in that situation, a positional sleep apnea happens. So if the positional sleep apnea is more, your patient will benefit from change of position, lateral position more than a supine position. So these have been tried, and there are a lot of devices have been described, not commonly available in India, but this is a FDA approved device. A simple foam, a pad on the back of the patient. If the patient lies supine, it will not be comfortable for him, and he'll automatically turn to lateral position. So the tongue protrudes forward, mandible protrudes forward, and the choking episodes or a pharyngeal diameter will improve, and the snoring will reduce as well as the apneic episodes will reduce. There are so everything is getting smarter. There are smarter devices which vibrate. So if patient is in supine position, the device starts vibrating and it disturbs patient sleep, and they go back to the lateral position. Gradually, like a Pavlov's reflex, gradually patient adapts a lateral position sleep. Not available in India at present, but they are not as good as CPAP. CPAP is one of the best therapy available, but long term it can be used in combination with CPAP. A lateral position sleep can be used with electromodulation like hypoglossal nerve stimulation or with help of oral appliance as well. Other positive pressure therapies, if you generate a negative pressure in the airway or a positive end expiratory pressure, your airway will remain patent. So there are nasal bongos, there are ulti-PEP device, there are negative pressure devices not available here. One of the patients procured it from US who benefited initially, but weight went up and ultimately went on CPAP therapy. Muscle training. Dr. Khare talked about the yoga, these asanas, which will help you to strengthen your pharyngeal muscle. Our physiotherapy or speech swallow people can help you to which therapies, muscle training should be done. Apart from that, those who are lazy people, you can train the muscle help of neuromuscular stimulation device called as Excite OSA, going to be launched in India, which is every day 20 minutes tongue stimulation will help endurance of the tongue muscles, genioglossus, and prevent the falling back of the tongue at night times. Can you only give oxygen? And the majority of times this question comes. Sleep apnea, desaturation detected, and only oxygen was given to this patient. So don't do that. If patient has nocturnal desaturation, it means he has engineering issue with respiratory drive. His ventilatory, milieu interior has been disturbed. So oxygen therapy can convert a central apnea to obstructive because of preventing prolongation of apneas, but sometimes it worsens the apnea. It doesn't have any impact on the patient's comorbidities. So standalone oxygen, no for the OSA management. But on CPAP, if patient still has hypoxia, you can consider adding oxygen therapy, especially those who have respiratory comorbidities and all. So coming to our patient who, we gave him nasal mask with a chin strap, started using it, but still feels his symptoms are not dissolving. He has excessive daytime sleepiness. And you will have these patients in your clinical practice. This is a real life patient. So despite of doing everything, he was saying, I'm still feeling sleepy. So what can be a reason? Either he's not using CPAP properly, either there is a leak. We tried to fix the leak. We tried to get his AHI. His AHI was not budging much. His respiratory events was constantly seen on those, despite of improving the pressures. But suppose there are no other similar issues, you have to look at alternative diagnosis, like this patient has, depression, anxiety, circadian rhythm disorder, working on the UK and US timings. His sleep cycle is disturbed compared to his family. So when he's trying to sleep, his kids are putting TV, his sleep is disturbed. His complete circadian rhythm disorder has developed. I'm not going to details of that, but these are the smaller issues need to be addressed by sitting with patient's family. So can you improve patient's daytime sleepiness with help of some medication? Modalert, I think everybody has seen and probably used it. Modalert is one of the medication which can help you to some extent to improve the patient's sleepiness despite of using a CPAP machine. But what could be other reason in this patient? This patient had a home sleep study done. He was cardiac patient. He has ejection fraction of 47%. These are the patients who are at risk of central sleep apneas or something called as Cheyne-Stokes breathing. So this patient came to us again that I'm feeling better, my sleep is better, but my daytime sleepiness is still persistent, I'm still feeling fatigue. What can be? So we spoke to the cardiologist, his cardiac optimization was done, we gave him Modalert, we have modified his mask, we gave him the hybrid mask, nasopharyngeal mask, but still he had symptom. So we requested him get on a discount rate from the Apollo Hospital. We asked them to give a titration or a split night study for this patient. And this patient who developed something called as treatment emergent central sleep apnea, the complex sleep apnea terminology. That's why I'm saying your job doesn't end at prescription of CPAP. This patient has to be followed properly by a trained person so that you can contribute fruitful lives to your patient's, fruitful years to your patient's life. So what is TESCA or a treatment emergent apnea? Your patient purely had obstructive sleep apnea, but when he was given CPAP therapy, his EEG was done, and we found that there are treatment emergent. On treatment, patient is developing central sleep apnea. Because of the loop gain issues, because of the arousal threshold, he's landing into a central sleep apnea phenotype. He still had symptoms, excessive daytime sleepiness, awakening, choking episodes sometimes. And always look at whether his central sleep apnea can be explained by opioid use, some medications which can induce central sleep apnea, central hypoventilation. So those things has to be ruled out simultaneously. So this patient was purely a case of treatment emergent central sleep apnea. So what we did a titration study for him, and we saw that these central sleep apneas are actually emerging at a pressure of 14. So you can reduce the pressure. At a lower pressure, patient can still be given CPAP, or some patients who are not likely to stick to the treatment, you can consider alternative modality of the PAP machine, which are BiPAP ST modes. That is a backup rate. Patient stops breathing, machine will give a breath. Or you can use the adaptive servo ventilation. So, but this patient is a cardiac patient. Remember now, these are the notorious things. ASV, adaptive servo ventilation, has shown mortality in some studies in patients who have EF low with central sleep apnea. So a BiPAP with ST mode was used for this patient, beautifully responded. On follow-up, AHE, apnea, hypopnea events dropped less than 5. He's happy, family is happy. His cardiologist said some magic has happened with one medicine, and we gave one machine. We gave him IVAPS mode, which is available with ResMed, or AVAPS with Philips. So this patient was oronasal mask. So modified nasal mask was given, BiPAP ST mode was given, and his symptoms came down significantly. AHI reduced significantly. So every patient, troubleshoot the PAP issues, personalized care, identify what is causing problem, and patients are right most of the times. They are not refusing the treatment, they are not reluctant to the treatment, they are troubled by the treatment sometimes. That's why they insist on refusing it. So always spend some time with your patient. We have been blamed of spending more time with our patients. 30-40 minutes we spend sometimes, but these are the issues which will prop up. So look at these issues. If the patient still says, I don't want to use a positive pressure, I'm going to use an alternative therapy. So couple of slides on that. Something called as oral appliances, which is a maxillary or a mandibular advancement device, which can be used when a mild to moderate sleep apnea, not for the severe sleep apnea or not this kind of patient, but a mild to moderate obese patient has retrographia or a large tongue. These kind of trunk protruding devices can help you, or mandibular advancement device can help you. Again, the problem, long-term problem is excessive salivation, TMJ joint pain. Sometimes the TMJ joint fixation has happened on that. And we need to have a proper dentist, MDS person who can help us with this, and it's very difficult to find this kind of trained people. Again, the cost is involved, and those who get benefited, it benefits in 60 to 70% of times. Otherwise, again, you have to go back to your PAP therapies. So that becomes your central treatment. Among the surgical things, I think if you have a fixed obstruction, address the obstruction. Adenoids, tonsils, resect it. Take a help of your ENT. If there is something called as drug-induced sleep endoscopy, you give a sedative to the patient, do endoscopy and see which part of the airway is collapsing more. It's a circumferential collapse, it's a tongue falling back, or it is a paratonsillar fauces which are coming closer. Accordingly, you can decide about resection, which resection should be attempted in an individual patient. Those who are completely reluctant, those who do not have this kind of obstructions, you can consider pediatric surgery for them. Another emerging treatment is a hypoglossal nerve stimulation. This is my couple of last slides. So if you, hypoglossus or a genioglossus, hypoglossal nerve or a genioglossus muscle is the basis to make your airway patent. A lot of nerve supply has been shared with the pharyngeal muscles and omohyoid and hyoid muscles. So a protrusion of the mandible, pharyngeal dilator activity can be achieved by stimulating this nerve. So who should, this should be recommended, who has BMI less than 35, who are not tolerating CPAP, who has moderate to severe sleep apnea, but there are no central apnea. We are talking about obstructive sleep apnea. Only there the nerve muscle stimulation helps. For central sleep apnea, you still have to rely on your BiPAP machines. Your sleep endoscopy shows there is circumferential collapse. So you have seen the collapse, you dilate the muscle and patient feels better. Again, those who have neuromuscular disease, those who have implanted devices, AICDs and all those, better to avoid another electric device because it gets implanted. You can see the pacemaker is implanted on the chest. It is synchronized with your diaphragmatic movement, and an ENT surgeon can help you to put electrode in genioglossus. When your patient breathes, same time the genioglossus is also triggered. So your upper airway is dilated, your diaphragm is pushed down, your airway volume goes up, your airway dilute, the airway is stretched. So the upper airway stretch further and the OSA events go down. Similarly, your oxygenation, carbon dioxide and other metabolic cascade is turned off. But it has been effective in certain number of patients. We don't have much Indian experience on that. Many devices available, yet to be approved in India. So our patient Mr. James Bond, who was diabetic, hypertensive, IHD, ejection fraction 47%. Remember, those who have compromised EF are likely to have a central sleep apnea or a central Cheyne-Stokes breathing for that matter, who was not tolerating therapy. We gave him oral mask, we gave him chin strap, then we changed it to a hybrid mask. Still he had symptoms. His OSA came down, but his symptoms were there. So educate, titrate the PAP therapy. If the patient's compliance is better, reassess them, look for the symptoms. If the symptoms are still persistent in these situations, you can consider in-hospital study. And then this patient received a BiPAP ST hybrid mode. Patient's tolerance went up, patient compliance went up, the PAP download showed significant improvement, his symptoms went down, and now this patient travels with his BiPAP machine even in airlines. Lot of forms he has asked to fill. I want to carry my BiPAP machine everywhere I go. His quality of life changed tremendously, and this can be your patient in your clinical practice. So please look at every patient carefully. Your journey doesn't end at prescribing the CPAP machine. So OSA, heterogeneous disease, one size doesn't fit all. You can look at the multiple options we provided. Think beyond AHI, patient's symptom, oxygenation, comorbidities, lot of things matter. A phenotypic guided treatment will help of, you can use imaging wearables. Nowadays, there is a My Air device, device 11th generation device, which can help you to get a smart card reading on your mobile phone, provided by this ResMed. So, every day's patient's journey can be tapped. Adjuvant therapy, lifestyle modification should be offered and treat the patient as a whole, not just the airway, to give a meaningful life to the patient as well as make your life easier with sleep apnea patients. Thank you.
Thank you, Dr. Pawan, for a very informative and engaging talk. So just one point I would like to add from the nephrology perspective. Obstructive sleep apnea and obesity is also a major driver when it comes to albuminuria, kidney disease progression and hypertension. So this can actually be a very good and a very important metabolic reversible factor in patients with chronic kidney disease. In terms, we have a lot of data to show that treatment of even a modest weight reduction and treatment of OSA can lead to a substantial decline in albuminuria, improve the GFR trajectories, and also slow kidney disease progression. So for the right patient, this can be a very good metabolic intervention.
Absolutely.
Thank you.
Any questions from the audience? Okay, just one question then. Actually, you kept harping on the EF and I was curious. I'm sure the heart failure medications were optimized. Did you have any covert signs of decompensation of the
Absolutely. So before going for any sleep testing, the patient has to be optimized from primary point of view. Because excessive fluid will cause hypoxia, and hypoxia will cause lot of detection of hypoapnea. So your AHI will be falsely high. So before sending patients so it should not be the sleep testing should be done in ICU or should be done in ward. It should be optimized patient. It is an elective procedure. Medical, you optimize the patient. If the patient qualifies, yes, he has standard sleep apnea phenotype, should be investigated.
I think we all can agree Dr. Pawan has given a very exhaustive and a very comprehensive approach to sleep apnea management, not just the prescription of the machine and the pressure changes. So,
thank you.
Great job. Thank you.
Thank you.
you, sir. I would like to invite Dr. Bhumika ma'am to felicitate speaker and chairpersons. For the next session, I would like to invite Dr. Vishal Gupta sir on the stage. And as a chairperson, I would like to invite Dr. Girish sir and Dr. Divya ma'am. Dr. Girish sir is a distinguished neurologist associated with Apollo Hospitals. With more than a decade of experience in the field of neurosciences, he holds an impressive academic background, MBBS, MD in General Medicine and DM in Neurology. Dr. Divya ma'am, she is consultant in the ICU at Apollo Hospitals. She is an accomplished critical care physician with an MD in Internal Medicine and has led ICU services including COVID ICU with exceptional dedication. Thank you. Dr. Girish, please introduce Dr. Vishal Gupta, sir.
Hi. It's a pleasure and honor to introduce Dr. Vishal Gupta, who happens to be a bit of a colleague near my practice in Kharghar. I think he does the bulk of his practice there. He's also very passionate about sleep medicine. In fact, just as I walked up to the stage, Dr. Jayalakshmi was telling me that, in fact, you are the person who inspired her to look at sleep medicine with a lot of seriousness, and that's how this whole journey with sleep medicine, our shared interest in sleep medicine started. So Dr. Vishal has his MBBS, MD, NB degrees, special training in sleep medicine, special interest in allergy immunology, and he pioneers allergen testing and other areas that overlap with pulmonology and allergy. Over to you, Vishal. We're looking forward to hearing from you.
At the beginning, I'd like to thank Jayalakshmi Madam for giving me this platform at Apollo Hospitals, as well as Girish for a generous introduction. I'd like to start by saying that I was inspired with ma'am to see that sleep can grow in pulmonology, because as most of the departments in India are being run by pulmonologists and with neurologists, so that is a very big venture where we can participate as a team. And sleep truly teaches us that it's not one disease, one doctor concept. So my topic, I'm happy to just ask a few questions. I think there are only 5-6 people. If they can all come to the first seats, it will be easy to discuss. How many of us have had a normal sleep today, sir? 1, 2, 3, 4. Among doctors, we don't get normal sleep. So all the others, have we had a normal sleep yesterday? All right. I assume that out of 3, 2 people have not had a normal sleep. All right. I'll have to go in the interest of time. But I was expecting to get that you ask the question to the patient, what is the time that you got into bed, and get an answer that, okay, somewhere around 9:30, 10 o'clock for a village patient. The city patients at 1 o'clock they sleep. Time to fall asleep, it takes them a lot of time to fall asleep, but that's the diagnosis that we're looking at. But in the normal scenario, we should be getting anywhere less than 30 minutes to fall asleep. And how many total hours were you in bed? It's an important question for our patients. Most of the doctors in their practice don't have the standard format to ask a sleep history. This is the standard format to ask a sleep history. So if you want, you can take pics of it. And what time do you wake up in the morning? What time do you go to bed? When did you feel that you felt that you get out of bed? You can ask the spouse as well if the person is there available for these questions. Along with nighttime awakenings, so usually the spouse will complain that he's getting up too many times in the night, and patient may recollect 1 or 2 events. So usually the coherence between the spouse and the husband is a unique part to sleep history, which is not there with other histories, where you take the patient's history himself. Usually the spouse history is what also matters here. The normal sleep is basically what you feel in the day as well. Most people feel that sleep is about what you have at night, but it's also about what you have in the day. That is what matters. So it's important how the person has experienced daytime naps, or if the person has been exercising in the day and has any difficulty doing these regular day-to-day activities, if they see differences between their weekdays and weekends, or if they've had any caffeine, alcohol, nicotine consumption and that has impacted their sleep, if any medications have caused this issue, whether any TV or mobile phone or other LCD screens have been having any impact on their sleep. Along with that, what is their basic understanding of? When they are sitting in front of you, what do they think that they have had a problem with? Like Dr. Pawan said, I think it's very important that our patients are listened to, and most of the times they are quite right. Because when we try to correlate even in a lab or at home, the sleep quality-wise is predominantly going to be decided by what the patient feels. And their feeling is 90% appropriate in my opinion. And there are very few patients who will tell you that they have a sleep disorder and they don't have any symptoms. But yes, those with cardiovascular morbidity and the neurological patients, they definitely, you need to get an objective evaluation before and also correlate with the subjective findings. So basically what a sleep diary is basically a tabulation of all of these events, and this can be the sole diagnosis of all of the sleep disorders, including sleep apnea and also other sleep disorders. So that's why its discussion here is quite relevant. So circadian rhythm disorders are basically the disorders when we see an abnormality in the circadian rhythm, and this is basically a situation where our ability to fall asleep and the actuality of sleep is different. So there is a slide on top. I don't know if the cursor is there. So this is a kind of a graph which plots the alertness and the sleep drive. These are circadian cycles which we discussed with Dr. Khare sir. He was talking about melatonin, he was talking about cytokines. That's where the circadian processes are in play. And this is sleep propensity and stress level. So your ability to fall asleep is fastest in the evening, while your ability to stay awake is the most in the mornings. And then as you sleep, the propensity falls, and then you can again go back to sleep the next day. Unfortunately, what is not tabulated here is the afternoon siesta, and that's a very interesting concept because you do have a dip in the afternoon. That is why people have actually recommended taking the nap in the afternoon. What we classify as normal is very difficult because the question to the audience would have been, what do you feel is normal sleep? But it varies with age. Please remember that a child will have a normal sleep somewhere between 12 to 9 hours. This is depending upon which age they have. An adult will have it around 8 hours. That is a normal sleep. Some people, apart from Elon Musk, believe that it's 7 hours. He believes it is less than 3 or 5 hours, which is totally absurd as per the national or the international guidelines. And 11 hours can also be taken to be normal for some people, including the teens. However, for adults, the older adults, which is the geriatric population, they tolerate sleep deprivation very well, but then their cardiovascular and other morbidities and mortalities increase. Along with that, some people report 5 to 6 hours of sleep, which is perfectly fine, but it should always be tried to optimize up to 7 to 8 hours. My association with sleep is very important because certain of the medications that we use in pulmonology and in other diseases have cross interactions during sleep. And this is important because I think every specialty has a drug which causes a sleep problem. Cardiac, neurology, gastro, psychiatry, all the medications that we use have some or the other interaction with sleep problems. So I think by the end of the lecture today, we are all quite exhausted with the volume of work that has been done before me. I'm sticking to only 4 big problems that we see as clinicians. The first being insomnia, which is a very simple problem. You don't want to sleep and you don't get sleep. At the same time, you want to sleep, but your sleep gets broken up in between. A narcolepsy issue, which is sleepiness, more so seen by neurologists and by pediatric neurologists mainly. parasomnias, which we see as many different domains with different medications and different problems, and circadian cycle problems, which has been discussed, and the most favorite of mine is jet lag, which is probably going to be something that the world will see in a big way in a few years. Insomnia is a condition where somebody has the time to sleep but can't go to sleep, which is initiation difficulty or difficulties keeping them asleep. India is again a huge majority of population problem where we have an insomnia issue for a variety of reasons, both environmental related, biological related, stress related, disease related. But on an average, 1 out of 3 Indian adult males, not the elderly, has got insomnia. This is a 30% predominance in the entire population. No disease can even come close to this prevalence. And if all diseases were to be combined, they would come somewhere close to this prevalence. So in my opinion, actually sleep diseases or insomnia in specific is the most prevalent disease in any situation. And the elderly have 80% or 60% predominance, 80% in comorbidities and 60% without comorbidities, and this is higher than the global average. So very often people come to us and they ask us, I can't fall asleep, give me a medicine, or I have insomnia, please give me a medicine. That is the biggest difficulty in understanding in a clinician's mind what is insomnia and what is insufficient sleep syndrome. So somebody who doesn't get enough time to sleep or is sleeping less is somebody who is insufficient sleep syndrome, versus somebody who has plenty of time to sleep or he is oversleeping and has a very difficulty initiating sleep and breaking sleep is insomnia. Please understand that insufficient sleep syndrome will react badly to benzodiazepine drugs. This is the reason why I put this slide up, because most people will be happy to prescribe a medicine, and especially general physicians. They say patient is not able to sleep, give him tablet. And then the next day he has drowsiness. This is because the patient was insufficient sleep syndrome. In the treatment for insufficient sleep is basically ask the patient to increase his consistent hours of sleep or take weekend naps or daytime naps in between. So the solution here is to look at the slide and understand that there are 2 different problems: insomnia with an I and insufficient sleep also with an I, but both are not the same eyes. So we have to solve the problems based on what their particular issue is, whether they want to sleep and they can't sleep, or they have slept enough and they are not able to sleep. And this is where the sleep efficiency, daytime compliances, and their core issues will be different. All right. I've put this slide up only to further enumerate that there is a problem with our medical thinking, that the way we treat our patients is important. The protocol has been laid out how to treat patients with chronic insomnia, which means that 3 days per week he is not able to sleep for more than 3 months. The first treatment should be not a pharmacotherapy. It is CBTI, which is cognitive behavioral therapy for insomnia, which is the simplest treatment that we offer to our patients. I'll come on to the next slide for that. Also, we should ask the question of isolated sleep, that is the initiation difficulties or maintenance difficulties, and the most important thing is in the elderly, in those with neurological condition, cognitive dysfunction, patients who have difficulty speaking out or hearing or other issues or processing their day-to-day activities, or when patients with concomitant tramadol or opioids, you should not be prescribing benzodiazepine drugs. The rest of the drugs like Ramilton, Doxepin, the Zolpidem, they are all quite safe. So please try to use those medications in the appropriate driven scenario where it is relevant. And benzodiazepines should be as a choice only when the next day morning residual sedation is not a big problem or the patient has been well understood by all parameters. Cognitive behavioral therapy is a very simple treatment. You can deliver it. You can do 5-column understanding. First is ask the patient to have proper sleep times, always avoid screen, avoiding tea, coffee, alcohol and other stimulant medications. These things should be looked into his prescription. Stimulus control, the patient should be using the bedroom only to sleep, leaving the bedroom when he cannot fall asleep, and he should come back when he's trying to fall asleep. Of course, not exposing himself to bright lights in the meantime. Restricting sleep times to the only time when he is going to go to sleep. Do not try to nap on the sofa, nap on the floor. All those attempts should be bad. They should be discouraged. And always increasing the in-bed time for sleep, especially on the weekends. Most people these days have got bad habits of watching Netflix over the entire Saturday evening. This is a serious cause for insomnia in the urban population. Relaxing and attempts to try to calm down are also very effective, and structural rethinking about how they should do it. The last thing was to revise the same thing again and again. So trying to improve the confidence your patients will get through your attempts to try to get the insomnia under control will actually do more than the medication will. What is circadian rhythm sleep disorder? I think Dr. Khare had covered a vast number of things that are going on in the body. My job is to just summarize on that point. You have melatonin, you have blood pressure, you have core body temperature, you have deep sleep phenomena, you have got the same thing happening in different cycles, your body coordination time, your mind, your alertness, all is being synchronized with the clock of the hour or the day and night, and that is where the importance of a circadian cycle lies. This is the way we diagnose our circadian rhythm sleep disorders. This is not a disease, it's called a disorder because we normally experience them in a different to different age group. In an elderly patient, we will see people who sleep early, get up early, they have total 8 hours of sleep, they are perfectly normal, but they have no symptoms, and this is complained of most by the relatives, not by the patient. You ask the patient, are you feeling sleepy? No. Do you feel asleep? No. Do you get up at 3 o'clock? Yes. Do you do yoga after that? Yes. You have any difficulty doing it? Answer is yes. This is advanced phase sleep-wake disorder, very commonly seen in the elderly population. Delayed sleep-wake disorder is a child or an adolescent or a teen who is sleeping late, getting up late, and not able to go to school and college in the early mornings. This is somebody who is also very common. You ask the kid if you are able to sleep late at night. Yes. Can he perform normally in the exam? Yes. Does he listen to his teacher? Yes. Is he falling asleep after 1 o'clock in the afternoon? No. That means that he is having delayed sleep-wake disorder and he is having 8 hours of normal sleep. The others are very interesting things which can be discussed at length some other day, but there are irregular sleep-wake cycles, non-24-hour sleep-wake cycles, shift work sleep-wake cycles, and there are jet lag prototypes which I am sure Jayalakshmi and Dr. Jayalakshmi Madam and Bhumika Madam are also well aware of. So narcolepsy and the hidden burden, which is very unique to us because as pulmonologists, we don't see a lot of narcolepsy patients. We do see a lot of idiopathic hypersomnia, but we don't get to see a lot of narcolepsy. We do not get to see a lot of cataplexy patients. The diagnostic criteria have been laid out. They include daytime symptoms like cataplexy and nighttime symptoms like sleep paralysis, hypnagogic hallucinations, and a consistently difficult ability to stay asleep in the daytime. They have reported a high global prevalence, but in India, we have not seen a lot of prevalence. In very specific studies only it has been reported, and I don't know of any personally treated patient of narcolepsy that I have seen in the outpatient. The treatment involves basically giving medications for stimulation and to counter the cataplexy, which involve medications like sodium oxybate, pitolisant, and venlafaxine, among other medications. Restless leg syndrome we see a lot. So it is a situation where we have itching, tingling, aching and crawling sensations in the legs, a burning sensation in the feet, most predominantly over the volar aspect, that is on the sole of the legs. Along with that, we see this particularly in a specific situation, more in females, and more to do with iron deficiency with CKD patients or kidney issues, and in pregnant women. And its prevalence is very, very high. Actually, this prevalence has been reported in 15%, but I would say that in the neurology practice, I think you will give me more values to be very, very honest, because they have to treat more patients there, so the reporting is very biased from different fraternities. The treatment for restless leg syndrome basically is through lifestyle changes, exercise, leg massages, and hot baths. And medications like dopaminergic agonists like ropenolol, pramipexole, along with iron supplementation, gabapentin, pregabalin, and sleep aids for benzodiazepine can be rarely used to provide a solution to these RLS patients, but at times the treatment can last quite long. Physical treatments like pneumatic devices and transcutaneous nerve stimulation give only symptomatic benefit, so we avoid using this because it cannot be delivered at the patient's home very conveniently. The last topic is more to do with neurology, but at the same time, we do see a lot of patients who are parents who come to us and ask that they have kids who have certain symptoms like sleepwalking or night terrors or nightmares or REM behavioral disorders are quite unusual for us, but neurodegenerative conditions like Parkinson's have a lot of these issues, especially sleep-related problems where the person gets violent or he starts walking around, and these issues can be solved through medications, but the most important thing will be an appropriate diagnosis and a clinical scenario that fits exactly in this. And with the differential of nocturnal epilepsy, we should be very, very careful, because these kind of patients can respond to medications but will relapse once the medications are stopped. I am thankful that I finished in time and saved everybody the effort. We can all break for tea. Yes, anybody questions?
Thank you, Dr. Vishal, for very comprehensively explaining sleep disorders. I think with the prevalence that you said, around 32%. So I think it's one of the factors which is directly impacting the health of so many people who are otherwise healthy. It will become one of the major comorbidities, I think, in the future.
Actually, fantastic job, Vishal. In fact, I was reminded of one of the very interesting articles. We have the JNNP, the Journal of Neurology, Neuropsychiatry, and Neurology, Neurosurgery, and Psychiatry, and they have very interesting topics for their review articles. So one of the review articles that I read, the spectrum of things that go bump in the night. And that was how they described all the parasomnias. Very, very interesting. And unless you take a very focused, dedicated history, it doesn't come up. For us as neurologists, RLS is of particular interest, and also REM sleep behavior disorders, because it is a form first or an early marker for all the synucleinopathies. So Parkinson's disease, Lewy body dementia, multiple systems atrophy, and to a certain extent even the tauopathies, PSP, frontotemporal dementia can have decades before the dementia or the extrapyramidal sort of syndrome appears, decades in fact, you can have the REM sleep behavior disorder, the nighttime behaviors, etc. And that's very interesting. And in fact, a lot of our referrals to a sleep lab is to try and understand whether what the patient or the bed partner is reporting is actually meeting the diagnostic criteria for an REM sleep behavior disorder. I think you did an absolutely fantastic job. Beautifully done. Thank you very much. Any questions we are willing to, we would love to hear from the audience.
Yeah, so CBT has workshops. CBT stands for Cognitive Behavioral Therapy. That works for, so I'll just finish that. So CBT has a lot of workshops. You don't have anybody to do CBT-I. The difference what you or maybe I do in my practice is what you can do is you can just jot down those points, revise the patient every time he comes to the outpatient. You don't get workshops for CBT-I because it's so prevalent that nobody has to make any money out of it. It's so problematic that if you tell the patient, he's going to throw it back at you. CBT, they take it very well because that is what the shrinks do in the US. So that is very popular, and they have training courses for that because it is very extensive. It covers psychiatry medications, it covers those with opioid drug abuse, it covers a lot of events. And it's a group session and then single session, and multiple things are going on. But CBT-I, I think it is delivered very easily through the online platform or through our apps, and more so with the doctor himself. If you just jot down those things, that slide if you want, I'll put it up. You can use this easily in your practice. You just have to tell your patient, see, do this and see tomorrow you will have results. And 90% of the time they will have a result. Very few people will fail on a CBT-I if you talk about it as your first and most important thing. Because patients are attentive only for a small span. They also sleep deprived. So they are only going to be attentive for first 2 minutes, first 3 minutes. Capitalize on that CBT-I delivery only that time. Even for us, it's not particularly possible to do a workshop for it.
Again, just a little thought as the questions are coming up. Inability to sleep, poor quality sleep is extremely prevalent. In neurology practice, almost every other, I would say 40%, 50% of our patients will either mention it as a primary complaint or as they're walking out of the consulting room. And unfortunately, I think this is something we can all put our heads together around. There is a absolutely unacceptable overprescription of one particular benzo, which is alprazolam. It's so prevalent, and once people are on it, it's very difficult to get them off. As a neurologist, we see long-term use very important role in two problems with the elderly: cognitive impairment and ataxia. They develop a weird benzodiazepine ataxia, which I think is very, very common. If you look at a lot of our elderly, they walk like they're drunk. You pay close attention. It's a very subtle observation. If you just check the history, they're on a benzo, and most of the time it's alprazolam. It was started by for whatever reason, and I don't know how they managed to get that prescription topped up. So when we're trying to wean patients off benzo, like you correctly pointed out, CBT is a very, very important part to get them to unlearn that addiction to benzodiazepine. It's not easy, but if the patient is committed enough and you can educate them about the cognitive impairment and the balance issues that they're currently facing, for which they are in your office, and point out that it's actually a drug in your ongoing prescription that's causing the problem, it's possible. And now, of course, we have lemborexant, which works fairly well to take care of that particular insomnia of the elderly. In my own practice, I typically combination of lemborexant and melatonin. Works quite well, especially in the elderly. Also, if there is a coexistent neurodegeneration, for example, let's say Parkinson's disease, I find that suppressing REMs hits multiple things at the same time. You can get them to the REM sleep behavior disorder to come under control, better quality sleep, and with benzos like clonazepam, excessive daytime sleep, not so much of a problem. It is a problem with alprazolam, but not. Any other thoughts, questions around parasomnia? It's actually very fascinating. Sleepwalking, narcolepsy, we see it maybe once in a year, a couple of times a year, the tetrad, but the form first in the form of excessive daytime sleepiness, one odd episode of sleep paralysis. That's pretty common if you look for it. So your comment on 90% being missed or undiagnosed or underdiagnosed is very, very true.
For us, it is a very difficult thing because we don't see narcolepsy as a pulmonologist ever. And it's very weird, or at least in my practice where I have a sleep lab, I don't have a patient referred to me by a neurologist to look at the narcolepsy aspect ever, last 10 years. So I'm just being honest with you. The fact is that there are worlds apart. There are differences that we have, but the fact is that there are unique aspects where we have to combine and understand what is exactly to be done, like insomnia, like circadian issues that we discussed very commonly. So for us, alprazolam is bigger a problem because the patient has decided that he is going to take it. And CBTI doesn't work when patient is already not in an unbiased mode. He's in a very biased mode. He's already ready to accept another benzodiazepine the moment you offer to him, or you give any alternative, it is easy to buy that. So I get that point where Ramilton is going to be probably very effective. He's ready to buy another medicine. Only that, unfortunately, alprazolam is quite cheap. So that becomes a conflicting factor, and we start getting a lot of people who do not want to give it up. Unless you start telling them that cognitive dysfunction is there and you are getting slower, you can show them the cognitive dysfunction is happening. He's unable to do his day-to-day activities, communicate normally, becomes violent, becomes aggressive when he doesn't get the medicine, becomes sleep deprived because he's not sleeping after the stopping of medicine. These are all real-time problems. And these are issues that our patients come and feedback to us. It's not about the books. So we do have patients, unfortunately, who do not want to understand their issues. At the same time, educating them, I think, repetitively, other than CBTI, has also played a major role. Not one visit is going to solve all problems. But we should stick to our goals. We should stick to our agenda. That's the idea here.
Reducing the noise levels in the ICUs at night is a different challenge. But for short term, I think we do use clonazepam in the ICU if there is a significant amount of sleep this thing. But we don't prescribe it afterwards, definitely, unless it is otherwise indicated.
ICU, ma'am, is 100%
This is something I'm, thank you for
patient.
asking this question, because for my own patients, there's one thing that really works. You put them in a bed that has a window to the outside world. Phenomenal benefit. And I tell the family, please try and keep them awake during the day. If the patient is reasonably stable, I even tell them, please do not lie down during the day. Sit with support, and I tell the family, don't allow them to doze off during the day. All of these things will help big time. Start with melatonin, right? And all the behavioral things, like for example, cutting down the noise levels, turning off the lights in the cubicle if you can, and keeping the curtains closed if that patient is not that very critical. All of these things help. But yes, getting a bed with access to natural sunlight, daylight, will definitely help. In fact, there was a study from Germany, I think it was from Dresden, where they shifted the entire university hospital's ICUs to floors that had glass windows. I mean, it's all glass, which means every room has an all-glass window to the outside world. And they found that delirium in the ICU patients came down phenomenally. So just the exposure to natural daylight and the feeling that you're not in some kind of a place where day and night makes no sense. I mean, let's take a person who's not unwell and put him into a room where there's only artificial light, which happens, for example, in my own consulting room downstairs. Yeah, it does play a role. It's not a good feeling at all.
So I think insomnia exists more in the doctors, less in the patients.
Oh, wait.
For the same reason, because her duty doctors are going to be doing nights and days and nights and days. There is no sense of day and night to a doctor who is doing this back to back. We've all done it in residency anyway. So it's a good question that you asked me. I'm understanding the muscle laxity is about the upper airway muscle laxity. Am I right? Pharyngeal muscle laxity. So there are terms where we look for what we call as, I'm sorry, I'm blocking the light because it is facing me. So the issue with the sleep study that we always do is we're trying to look for REM atonia. So rapid eye movement is a part of sleep where we look for jaw muscles and we're looking for fall of the jaw muscles. Your question is pertinent to, yes, do we look for a sleep study where the jaw is lax? Yes, we do that. Can we quantify it in numbers? No, we don't have numbers to put it at. So it's not like blood sugar that we have 100 and then becomes 60 and then we give insulin and then we give sugar and it goes back up. No, that reversal we don't check. There are techniques which we call as hypoglossal nerve stimulation where we get the opportunity to quantify it as well, but that's not a part of regular sleep studies. Also, there are two particular things which in a sleep study we want to look at always is something that is called respiratory effort. Okay, effort means the breathing inability that is coming from the stomach. It's not in the upper airway. And an obstructed effort is where we are looking for sleep apnea. So the idea is what we as a doctor do not get understood is that it's not just about laxity here. It's not about a fat which is compressing. It's not a tonsil which is standing in the way. It's not a central airway obstruction. What we are looking for is the effort present and the ability to draw in air. Is it getting blocked at a point or not? And that is quantified. So respiratory effort is quantified, but the collapsibility and the pressures are getting quantified either on a hypoglossal nerve stimulator or on the CPAP, like the pressures delivered and the P95 that Dr. had discussed. So Dr. Pawan had discussed. So that is where we quantify that. But on a study, we don't quantify it as a diagnostic study. Good question, but see, this is a multi-dimensional answer. Okay, the defect has to be repaired provided it is at one level only. Correct. That's called drug-induced sleep endoscopy. We go inside and then we check the area of the dilatation, which is... Absolutely, yes. No, you don't need. CPAP will help you just bypass that time for the surgery. It will help you buy time. CPAP is not always intended as the only solution. It's a take-home message. Do not think CPAP is the only solution for your lifetime. There are multiple options. And there are more to come. There are more options which are coming up and faster options which are going to be available because CPAP has a lot of limitations. Thank you.
Now Dr. Jayalakshmi will felicitate the speaker as well as the chairperson. To Dr. Vishal Gupta. To Dr. Girish, sir. Sir, please. And finally, Divya ma'am.